Boa tarde a todos e todas que nos assistem. Sejam muito bem-vindas e bem-vindos. Meu nome é Milena Serenini.
Good afternoon, everyone. I'm Sirene, nutritionist and the coordinator of the Ministry of Healthcare. I'm gonna conduct the first panel and the second day of the second International Seminar of Nutrition and Primary Healthcare. The second seminar is an initiative of the General Coordination of Nutrition of the Ministry of Healthcare in partnership with the Pan American Health Organization. This event is being broadcast in the channel of OPAS Brazil to the languages English, Portuguese, and Spanish. Today we're going to start the agenda guaranteeing the nutritional security and the human right to proper nutrition in childhood. After that, we're going to have a panel that will share international experience related to the challenges and perspectives of the nutrition policies in the context of primary healthcare. And we're going to have the presence of representatives of Canada, the United Kingdom, Trinidad and Tobago, and from other states in Brazil, and Tocantins and Paraná. Our team is going to be paying attention to the chat to receive comments and questions. We remind you that the important deliverable of this seminar is the construction or the writing of the second letter of Brasilia with information for public policies and for national health cares. Therefore, I invite everyone who is watching us to access the website of our event and contribute with the construction of the second letter. It's also available in the seminar website, the documents that were released yesterday, the matrix for the organization and the cares and the primary health care nutrition, the recommendations for the nutritional care and the primary health care in Brazil, and and uh, the and to start the activities this afternoon, I invite Dr. Gisele Bortolini, National Coordinator of the Ministry of Healthcare and Nutrition. Dr. Gisele, welcome. Good afternoon, good ladies and gentlemen, all the attendees in this second international seminar. And I'd like to welcome you all and say that the debates were very rich and they're going to, as it was described. And yesterday we had the opportunity to talk and understand about the advances and the challenges and the opportunities of the nutrition and agenda, starting with using the perspective of PAHO and CONAS and CONASIMS, which is the National Secretary Council, the WHO perspective, and the National Council of Health perspective, showing many different challenges, advances, and recommendations to move forward in this agenda. Besides that, I'd like to highlight yesterday we published two materials that were very important and are going to contribute for the debate. And the debate is going to be broadened today beyond the scope of the primary health care to understand where we are inserted and the role of primary health care. I wish you all a great event, and I hope that all the debates are very fruitful and we're going to have recommendations and solutions to move forward in the agenda of nutrition in primary healthcare. Good. Thank you very much, Dr. Gisele, Ms. Gisele. And the first topic in our today is the planetary nutrition and primary healthcare. And it'll be conducted by Ms. Mayara Foss. She is a family doctor and community doctor from the Federal University of Rio Grande. And she's in her doctorate thesis in the University of São Paulo. She recommended about information about the climate change and did the Lancet countdown from 2018 to 2020. Ms. Mayara, welcome. Can you hear me well? Yes, we can. Good afternoon, everyone. It's a pleasure to be here in this event with you. Thank you very much for this opening. I'm just going to wait for a second so I can share my screen with you here.
seguir. Eu vou só daí pedir se alguém pode confirmar se está vendo.
So can you check, can you confirm if you can see the screen or not? Screen? So I can follow. Yes, we can.
Continuam vendo os slides agora?
Carregando.
Bom, enfim, vamos começando.
All right
Okay.
then. So let's start.
Pessoal, eu acho que esse tema da saúde planetária...
This topic of planetary health, and some other colleagues are going to talk about it later. That is a very important debate that we're holding, we're trying to build in terms of planetary health, and I had the task to bring, to consider it in the primary healthcare environment, and to go after the definitions and think with you. And if you're interested, if you have any questions in the chat, I'll try to have a look and answer it. So there is a country, we have a country that is very diverse in terms of biodiversity. We have the largest standing forest for now, the rainforest. We hope it continues this way. And that we also have this national healthcare system, SUS, that provides coverage for most of the population. And what is important in trying to understanding and talking about this topic in terms of planetary health? We have the traditional focus, which has to do with the environment. The environment is considered something lesser, less important. And I ask you, the clinics in which you work, do they sort the trash? And because that is also always considered a second or a third or fourth priority, so we have to prioritize the sorting of the trash in organic and non-organic. And sometimes we have activities in the community, and that is the traditional focus, and we don't put it together. So it's important to bring everything together, looking at the health, which is called the ecosystemic focus. So what is this planetary health? We have the greenhouse gases emission. You can see here this drawing, this representation. You can see the rainforest burning, chimneys, cattle raising ranches, and these gases are emitted, and it's impacting the quality of the air and the acidification of the ocean. And if you look at the right, it increases the temperature on, and it changes the rain patterns, and it raises the tides of oceans. And we also have more often natural disasters. We have calamity situations such as in the state of Bahia and now more recently in Petrópolis. It's not out of the blue. It is happening due to the impact in the environment, which is suffering. And for a very long time, the humans thought they were not connected to this, and they thought that the health of the environment was something disconnected to their reality. And I like using a picture of Moebius, and if you look at one side, nature, and the other side, humans, but we're actually connected to it. So the situations cause fires, droughts, floods, and heat waves that are connected to the loss of biodiversity, the collapse of ecosystems, plagues, the reduction of agricultural output, and the loss of the possibility of physical strength, because people get too hot and they cannot work well enough. So we lose biodiversity in the oceans, which is a major problem that we're studying recently concerning the plastic that is also going into the ocean as well. And the consequences for our health, such as and the other issues such as pollens and allergy, particulate pollution in by particulate matter and increase in ozone. So this also always affects many other aspects. We have longer droughts now that might cause migration and other conflicts that are caused by this situation. When we have a very strong and intense heat wave, this is correlated with the increase in the number of suicides. So we prepared to deal with or handle these heat waves that are going to be more and more often. So all of these effects are mental health care. There will be breathing or respiratory diseases. What about food security? How are we going to grant or continue, which is one of the central issues in our discussion today? What about heart diseases and the ones that are infectious as well? So just so you have an idea, if you have the rise of 1 degree and the temperature of the planet, we the vector mosquito that transmits the dengue fever will increase. There will be an increase of them in transmitting these diseases. They are very important issues for infectious diseases that are in this spectrum. So our planet is hot, and we are handing the next generations a hot planet. And I believe that we postponed this conversation and we used to say that, oh, the next generation will deal with this. And as if it was just a matter in the future, but it's not anymore. This is our current reality. We're living the consequences, and people have been dying due to the consequences of the climate change. And it's very important for us to look at the food security within this perspective, because the agricultural system of producing food is the second largest emitter of gases, and it's just second to the fossil fuels that are changing our planet and heating up the planet. So this discussion is central to know whether we are producing health. So I believe that most people that work here work in primary healthcare. And I wonder if we're producing more health if we have a hotter planet, a hotter country. And I believe that's something that we have to think about. Are the services dealing with the health? Am I sorting the trash? And if am I prescribing too much medicine? So this has a very intense carbon footprint. And if every country around the world pulls together and comes up with a list, all of the healthcares in the world come up with a list of the largest emitters of CO2, the healthcare is the fourth one, that largest emitter of greenhouse gases. So it would be like the fourth country that is making the country hotter. So healthcare is the carbon footprint is very important for healthcare. So 10% of the total of the energy consumption in the country comes from healthcare systems. This is at the core for us to think about the country. So if you can, please write on the chat what you think when you see this picture of that is chapped with which is an image that wants to provoke, to cause, that is thought-provoking. The country, the word territory that comes from Latin, comes from the word that means ground, earth, where we come from, where we step on, our origins. And when we see that we're part of this nature that is degrading, and our foot is part of this ground, and climate change are affecting us directly, it's really important for us to understand that we have to change the way we look at health and healthcare. So I'm going to try and instigate more thoughts. So half the planet is used for agriculture and cattle raising, but just 21% of the global area for agriculture is used for human production, for production of human food or food for humans. So we're basically using too much of the Earth that has a huge impact. So I wonder if that's the best way for us to produce this. Is it the best way for us to live and use these resources in our planets? You'll have more time later to look at uh, these charts here, and our world in data says that not all throughout the world is habitable, and we have part of the Earth which is so 71% of the whole planet is not inhabitable. And we're using a huge chunk of it for agriculture. So we have to start thinking about how we're using these resources and to think as a population what our goal is. And we've been destroying this. And one of the main issues that is causing deforestation in the Amazon rainforest is the logging for opening fields for cattle raising. So this is our issues that we have to think about and see that it's affecting our healthcare. And it's related to the insecurity in food production. So if we look at the country, the planet, this is a chart of the planetary limits and boundaries. We see that there are many limits that have been surpassed. And for example, COVID is a situation in which we have gone through the limits here. For example, if you look at where it came from, it has to do with the fact that many wild areas were being invaded and people didn't respect these wild areas. And people say that the Amazon might be a place where another pandemic might come from, and a virus or a microorganism that will kill millions of people because we are pushing the boundaries of our forests. And we know that we're living in our lifespan. We are going through the largest extinction of species and biodiversity in history. And we're losing every single day new different species. And that might not be so relevant, but it might seem not so relevant, but it is because we're causing huge disruptions in our country and in our planet. And that is an unsustainable way to live for humans on this planet. And we have to think that there is no backup plan. There is no planet B. We won't be able to settle and to create colonies in March. We have to take care of our home now. We have only one home, which is planet Earth. The issue of planetary health will look at these planetary systems and the cycles of phosphorus and cycle of nitrogen, and it will help us understand better how we can work. But I would like you to make you think about this, and it's an urgent call. We have to act now to try and build and to think of a planet now of a different way so that humans can be part of the system. And it's important for us to understand that we have to rethink the way we're dealing with health, because it's not going to be sustainable in the long run. So the NHS, which is the National Health System, already has a proposal of to have neutral carbon footprint that will not a system that will not be so impactive or will not impact so strongly. Why can't we think of a SUS here in Brazil that is greener, that will also help us deal with the residue production and when we are
pensar em trazer, e o Brasil já faz isso muito bem, a questão das hortas, por exemplo,
and to think about this and to think about to look about the local economies and local scale economies. And my proposal might seem too absurd or radical or hard to be achieved. But I wonder if that it is, you know,
Aqui
to
é
think
um
about
monitor de qualidade do ar
healthcare.
que
And
em
uh,
2018
and
mostrou
when we think about it, in
então eu fui para essa
2018,
época em Porto
when
Alegre
I was working in Porto Alegre,
apresentar os primeiros resultados do
I
Lancet
presented the
e percebi que a cidade não
first
fazia o monitoramento
results of the
da
Lancet, and I really realized that the city didn't
e a gente
monitor
ficou
air quality.
e isso é muito comum aqui no Brasil, não
It is very common here in Brazil. We don't have the monitoring of the air quality. So we pulled together a few doctors and we started to,
conseguimos com a Universidade Federal do Rio Grande do Sul
we
a
talked
parceria
about
para
it with
conseguir
the Federal
monitorar
University of Rio
corretamente
Grande
a
do Sul
qualidade
to
do ar
start
a nível
monitoring
nacional
the
para
air
algumas
quality
cidades.
when it came
Hoje a gente
to the
sabe que quando tem uma
local
qualidade do
clinics.
ar ruim,
And now we know that then when there
é
is
uma das
bad
causas
or
de
low air
AVC,
quality,
de problemas cardiovasculares, problemas
it's a main one of the main causes of heart
tem uma
problems,
relação já com Alzheimer,
and
com
it has a relationship with the
então saber
Alzheimer
como está a qualidade
and
do ar
cataracts as well.
é
So
essencial
being able to know
para
what the
pensar
quality, air
na
quality is
população.
essential
Quando
to
vem
think
alguém
about
tratar
the
com AVC, com
health of
infarto, a
a
gente sabe que
population.
simplesmente é
When
porque
there is a heart attack and when there is
será que não
a
é porque
stroke, we have to
teve um
measure
local
the blood pressure,
particularmente
but
então marcador de
we
qualidade do ar.
might also
Então
have to look
conseguir
at the
implementar
particulate
em várias
matter
unidades
to
de
try and
saúde esses
implement
sensores,
these
uma coisinha
sensors because we managed to
minúscula,
implement them. They're
e a gente
very
implementou em
little.
vários locais.
And we
Então tem
implemented them
muitos
in
brinquedos
in different places, which is a small
que a gente
sensor,
sabe
and we
que
managed to
isso nos
start
ajudou
measuring.
ainda está em processo, né? Mas a barrar no primeiro
This
momento
helped us get into the process of stop this. This is a mine of carbon that is open. This is an open air, which is going to be constructed in Porto Alegre from Latin America. How are we still thinking about to open a carbon mine in Porto Alegre or another region? That is very sad. So we were able to bring this, that show that the air quality was already not good. And with this project, it will get worse. So we need to measure the air quality. I think about how it's important to do these measurements in a region where there are wildfires. Children already have studies showing that within their womb, their mother's womb, they grow small or they have a reduction of growth due to the air pollution. So we need to look for into the air pollution, for the climate that is hotter, for diseases, for our health, and all these issues, and for our food security, safety through the many tools that we have in which we were able to advance in knowledge and not be only an boring environmentalist or something that seems that when you talk about environment, something that is apart from reality, this passes about for everything. So Lancet, which is a medical journal, says that the greatest determinant of health in this 21st century are climate changes. So we need to talk about this. I'm going to pass a video to you to watch it. Just confirm if there is a sound, please. Does it have a sound? Unfortunately, no, we do not have a sound. But it says we only have one home. They are now discussing about the lack of audio. Well, now I can pass to you later. I'm going to finish now my presentation, and then later I will try to do this. So what do we need to think about a healthy nutrition? So we have many issues. This is a material that was developed by this planetary group. They were talking about a reflection that we only have one house. We're going to try to build this with you. So we need many things. We need to have the academia, communities, urban planning. I also like to think about that there needs to be a rural plan to think about health nutrition and also management of resources, food industry, agriculture, public policies, public health, psychology, restaurants, and food courts. So this is infinite. Since this is a very multidisciplinary theme that passes through everything that we are thinking and that we have been building in relation to the planet health. So what can we think about when we're talking about the aspects? We think, oh, I don't know where to begin from. This is where we need to think about how to build this resilience, climate resilience. We need to adapt to these changes which are happening. We need to have plans or when we have these heat waves. We need to notice in ways for us to control air pollution or even to begin to monitor this for us to understand that we are impacting health through these actions. And then we need to bring all actions to reduce the emission of greenhouse gases, mainly those gases. And then we have a lot of small time to do that. I do not have the graphs here, but if we see now, even with the pandemic, we are increasing the CO2 level. So we need to mitigate this, reduce this, and think about actions of sustainable transport, clean energy, energy efficiency, and of course, reduce consumption. And we need to adapt ourselves. So we need to have protection against floods, improvement in the infrastructure, because if we know there's going to be heat waves, we know there are going to be floods, so we need to have an improvement in the infrastructure. We need to have we need to have contingency plans, and we need to think about the networks in food, in the energy the systems that are sustainable for the conservation of water, which I did not talk much, but you can explore a lot, education, and to think about the forests. And it's urgent for us to think about the Amazon when begin to put a protection in the forest, which includes to be able to allow that indigenous people have their land, to take care of our forests. So these are very important actions. Okay, something happened here. And then I'm going to mention the people that coordinated here, and they're creating and coordinated the course for planetary health from the planetary health for primary care. You can do the courses. We have a first version, which was the one that we did with the modules, and then it was translated by Planetary Health Alliance to English, and now there's many farms, many people in the world with the themes through Brazilians, and we have been building this with many hands in the entire world, a course that is focused in the planetary health and primary attention to health, primary healthcare. This is very interesting. I invite you to know this, to profound ourselves in this theme. The video is just 1 minute. I think I have a little time to pass it. I will try again I'm going to stop my sharing. Now they're saying for Miss Mayara to how she can share, and they're trying to fix the video and try to share it with the sound.
Link a gente passa.
Tá. Vamos testar de novo, então.
They're going to test it again. Now we have a sound.
Sim, estamos.
Você já pensou que só temos
Have you ever thought that we only have one house, that when there is a problem with your car or something in the industry, it will stop in our noses and lungs? Because when we burn the Amazon, we are burning a little bit of our house, our air and home. The scientific evidences show that diseases caused by pollution created 9 premature deaths in 2015, but 3 did more than the deaths by tuberculosis, AIDS. The increase in these diseases like dengue disease is connected to the fact that our planet is getting hotter. There is no planet B in many aspects. Humanity already passed through the limits of the planet Earth. That's why the planetary health is connected to characterizing these concerns caused by the community in the planet and the impacts resulting in public health, and what we health professionals can do about this to understand how the health of the planet and the health of humanity has to do with our course in planetary health. So although we have many challenges, the changes, climate change and planetary health are our greatest tool for opportunities to change the future. We hope that you can get into our course, Planetary Health. We only have one home.
Era isso, pessoal.
This is what I wanted to show you. So just to finish then later we're going to talk more. Thank you very much, Ms. Mayara. Awesome reflections for the beginning of this day. It is very important, this debate about health, environment, and humanity, and the role of the actions for food and nutrition and primary healthcare in this context. We have many people saying that this was very good, and so thank you very much. So now, next, I invite Ms. Kelly Alves, which is a nutritionist from the University from Alagoas and doctor in collective health by the State University of Rio de Janeiro. Nowadays, she is a technical consultant from ACT for promotion of health, which is an non-governmental agency that acts in the promotion and defense of public policies, health public policies in the control of food, control of alcohol, in physical education. She wants to talk about the role, the mediator role in the primary health care to guarantee food security and nutrition security and human rights to the adequate nutrition. So welcome and thank you for being here. Thank you very much, Milena, and all the team here for the organization of this seminar and for the invitation to collaborate with the debates in this afternoon. Now I'm going to share my presentation. Tell me if you can see it. Okay, we are seeing it. Since we have participations for participants from other countries, I thought it was necessary to begin my presentation by explaining a little bit of our comprehension in Brazil about the human right to adequate food and also about food security and nutritional security. So we understand this right as an inherent right to all people that refers to two dimensions: the right to be free of hunger and malnutrition, and the right to have access to an adequate and healthy nutrition. This right was included in our federal constitution in 2010 from a great mobilization from civil society and from the government at that time to include the right to food in the hall of social rights which are foreseen in our constitution. In this trajectory of fighting for the human right to adequate nutrition, the concept of health and food and nutritional security, which was built in our country and which is present in our organic law of this safety, food and nutritional safety, understands that the health and nutrition security is the performance of all the rights for everyone to the regular and permanent access to quality food in sufficient quantities without compromising the access to other essential necessities, having as a basis food practices who promote health and respect the diversity in which are environmental, economically, and socially sustainable. So our comprehension of food and nutritional safety in Brazil is about to which way do we defend in order to concretize this right to an adequate food nutrition in our country. So this security is understood in Brazil as a path to guarantee the human right to an adequate nutrition to our population. And this guarantee is done through a lot of intersectorial actions from the state, which are related to the many steps of the food system, from the production of the food until the consumption. So for us, the guarantee of food security as a path to make this right concrete is not done through any type of production model of foods or any stimulus through food practices. It is defended that the sustainability of the production processes, the consumption of food through food practices which promote health to humans and also to the environment. Another very important point to highlight is that within this trajectory to guarantee the human right to an adequate nutrition, we must preserve the guarantee of the other rights because they are not divisible and are inalienable. So to guarantee this right, they cannot compromise the guarantee of the other social rights for the Brazilian population. So we can see that in Brazil, to be able to do this proposal for health and nutrition health, it needs to have many actions and initiatives which are connected, be it in the food dimension that talks about the production, availability, commercialization, and the access to food, but also in the nutritional dimension, which is considered in our country about the food practices and the use and the biological use of food. So it is related to the choosing, the preparing consumption of food for our health. In this perspective of food and nutritional safety, we can identify as many phases of food insecurity when population does not have this type of security guaranteed. This can happen when there is a lack of physical access to the adequate and healthy food or through the means for its production and acquisition. It can happen also when the population has the access to an inadequate food, be it in nutritional, microbiological, or cultural levels. And also there is this type of insecurity when people need to compromise their other rights in order to guarantee their access to food. So insecurity, nutritional and food insecurity is not related only to hunger and malnutrition, but also to other facets of its manifestation. Having said that and explaining this part of our comprehension of this human right to an adequate food, now let's go within the role of the primary healthcare in order to guarantee these rights. So thinking that health security and nutritional and food security demand many intersectorial actions, the health sector has a role that is very strategic because usually the consequences from food insecurity, which provoke the bad health conditions and nutrition, they develop the services of our healthcare system. So in Brazil, the services for primary healthcare are the ones with more capillarity in our territory, which is a very big territory. We have is almost a continent, our country. So our primary care, healthcare attention, it has 54,000 teams, APS teams that work in around 50,000 basic health units. So this is where those teams work. This number of teams now covers around 168 millions of people, which is 76% of people in our country, of the population of our country. So for you to have an idea about the difference of capillarity in two services considered very important in our country, and that develop actions that contribute to food and nutrition security. So while in our unified health system, we have 50,000 basic healthcare units in each territory. In many territories, our unified health system, this is the Serviço de Assistência Social, which is very new one, and it works in the municipalities from reference centers for attention. It includes only 11,000 units. So with this capillarity of the services for primary healthcare in the territories, many of the times it is the team for primary health for the one that notices the situations of food and nutrition insecurity, or the one to be called for to face this for the people who live in the territories which they are responsible for. It is important to clarify also that in Brazil, we have a model for primary health care, which is still predominant, which is called Estratégia Saúde da Família, which is responsible for 64% of the coverage for APS, and the other models of team models which cover the services for primary health care. They are also have a basis that is defined of population and territory, but the characteristics of the strategy for family health that are about this delimited territory and the multi-professional team, including this multi-professional team, those people that are community agents, which are people that live in these territories, which are selected to work in these teams. These characteristics of this model for primary healthcare, which are predominant in Brazil, makes it possible to generate some potentiality so that this service or primary healthcare can contribute to guarantee food and nutrition security in the territories. These potentialities, I chose to mention only three here for the context of our seminar. So one of the characteristics is the possibility to recognize the food environment in the process of territorialization and consider it for the practices of care related to food and nutrition. Another potentiality is that these teams which work within this defined territory with a population there, they have more chances to do the organization of care practices which are more coherent with the local context through this reconnaissance of the environment and the situation of food security of the families in the territory. So then from its capillarity and importance in the territories, these services for primary health care can also have a mediator role alongside the other equipments of the territory. They can be protagonists in the procedure of intersectoriality in these territories.
So dealing with the potentiality of recognition of the food or food environment and the characteristics for the practice of nutrition and primary health care. So in Brazil, we managed to take a few steps to encourage and to propose ways for as the team of primary healthcare, the way they can include this knowledge of the food environment and the use of the information and characteristics to organize their practices and care. Our national policy in healthcare that was published in 2011 in the second edition includes in the guidelines the importance that the teams of primary health care include in the territorialization process, the identification, the production places, distribution, and as well as the habits and local traditions, food traditions that might help the team understand what are the conditions and determining aspects of the population in the state that they are caring for in terms of healthcare. After a few years, and the material that came out in 2017, focusing on the contribution of teams for food support, on nutrition support, this guideline for PINA had more detail in terms of guidance considering how the teams would be able to identify aspects in the food environment in the territories and the implication of these aspects for the work in primary healthcare. And it's also important to highlight when when these publications were made, we didn't have yet the understanding of food environments and nutrition environments that we have now in Brazil. The basis for the organization of this that was launched yesterday in the seminar could make use from different sources that talked about food environment in Brazil and include in its content a chapter that provides more guidance so that the primary healthcare teams will be able to map this the food environment during the territorial mapping and how they can include these aspects in the organization of their practices of care. In this matrix, it was possible to go forward in the discussion of this place that as part of the system, a food system that includes the production chain as well as the food production, and to highlight in the teams that the food behavior, nutrition behavior of the people for which they're going to be responsible for is a result of a person of these people in this food environment. And this food environment is part of a broader environment, a food environment. And that helps for practices that are more contextualized in the food environment where these people live. In this matrix, there was a chart that was included with suggestions of how the team can characterize this process. And it was an important step, but we still need here in Brazil to go to advance in the technical tools to facilitate this mapping and the analysis of the food environment by the professionals of healthcare and nutrition. The second point here, coherence in the practices with according to the local context, and the mediator role of these social teams along with other healthcare teams. The new matrix that was launched yesterday also brings some indication about paths for these teams to translate to use these national guidelines as our two previous food guidelines that were made. And the translation of these recommendations put them into practice in the local areas by after they identify these specific characteristics in the local food environment. These guidelines bring recommendations for the whole Brazilian population, and the group of food groups is going to include different types of food depending on the region of the country, municipality, and on the state as well. Food culture in Brazil is very diverse and very rich, so it's not possible to standardize this and so that all the primary healthcare teams will use the same information and the same guidance. These national guidelines as guides is important, but it's also important to recognize the local food environment. It's important so that these teams can use these guidelines and put them into practice in the local context of the population that is going to be helped by them. Another point for the mediator role in this service of primary healthcare and the articulation between the sectors and the territories is that we need to advance in the development of tools so these primary healthcare teams can develop this to have a protagonism in the mobilization and the articulation between the sectors and the territories where they work. So the handbook to identify these practices and the organization of network for nutritional support network in these territories is also an important step that was taken to contribute with these tools so these teams can analyze the security, the food security and situation, and beyond the nutritional data. And besides identifying the parameters of identification as of food that indicates in food insecurity, but also to be able to identify what network is beyond this territory, what are the potential aspects for articulation of public policies in a local aspect to collaborate with these families and people so that they can overcome their food insecurity situation. Another point that is important is that these primary healthcare teams need to have these conditions to play this mediation role to guarantee this nutritional situation. And something that is important that has to be improved is the recognition that this articulation between sectors is part of the process of work in APS. And we still have conflicts between the professionals and the managers. And and this work between this articulation between sectors, the promotion of meetings, holding of these meetings, and the establishing the strategies that go beyond the healthcare system, there are conflicts that this action, that this care provided by the primary healthcare teams might harm the activities that are performed by the clinical activities in these clinics. So it's important for us to work with the managers and the professionals to establish that these teams work in different territories, and there will be territories where the food insecurity conditions will be more severe, and they will demand from this team activities and actions that are not always going to be the same, that are that are made public for the basic health clinics, or UBS in Portuguese. And the managers have to understand this by analyzing the productivity of the teams, the healthcare production, sorry, the primary healthcare teams. We need to encourage and value this kind of action that is developed by so many professionals that make an effort to have this articulation between sectors and that work towards food security. And besides this recognition and support for this kind of action in the primary health care, we also need to highlight that it's also necessary to guarantee the necessary, adequate funding, infrastructure, and other working conditions for the professionals of healthcare can develop this range of actions that are possible for the contribution for healthcare and for the nutritional health security and these territories. So in a general manner, in our country, it is a challenge. The funding and the guarantee of these proper conditions of this our SUS system. And so we did have to highlight this. It's important to say that developing tools and capacity building activities for the professionals for the execution of this work, it's important, but they also need the guarantees, adequate conditions, working conditions, so they can put these actions into practice. That's what I had to say. Thank you very much. I'm available to continue the dialogue during the debate.
Muito obrigada, senhora
Thank you
Kelly.
very much, Ms. Kelly. Once again, a lot of compliments and on the chat. And I'd like to highlight that Kelly coordinated the women's team that created the matrix for the organization of care in nutrition, and that was launched here yesterday in the seminar. Thank you once again, Kelly. And before we start the debate of this panel, I'm going to invite Ms. Elisabetta Resini, nutritionist and doctor in public health care by the Federal University of São Paulo. Ms. Elisabetta is part of the the group of food policies observatory and the University of Brasilia observation group, and the high-level panel of specialists in food security of the UN. Ms. Elisabetta, welcome and once again, and thank you for your presence. I'm really pleased for this. Thank you very much. Since yesterday, I was remembering how much we have advanced concerning this whole agenda starting in the first meeting, both in terms of understanding this agenda, the role of public policies, and how the policy is made concrete in primary healthcare, and the concept of experience as well. It's very rewarding to be seeing such amazing debates and testimonials. I thank you for this opportunity. So I do have a mission that is complex to try and to bridge two different points, the two different discussions that of between Mayada and Kelly. Not that there aren't many. It's definitely sure that they are present, and I saw that the chat is very active here, and a lot of the questions and the comments are worthy to be mentioned and to be answered both by Mayada and Kelly. The first thing that I'd like to stress is something that is more panoramic concerning the views, the issues that Mayada mentioned, which would what would be a green SUS? And I was reflecting how far we are from this in many different ways, especially from the perspective of the paradigm and the management and the processes in SUS, not only the primary healthcare, but as SUS as a whole. These parts are so far from practices that are very basic that will guarantee a relation with what we usually produce and the consequences that we have in nature and other aspects. We still have point of view. And it's not only SUS, it's our society as a whole. We have a huge challenge to implement all of the dynamics that have been regulated and what we call niche in our society. So SUS has a lot of challenges to face concerning the medicine, the raw materials that they use, and the destination as well. But there is also another expression of this paradigm of green SUS that is connected not only to the professional's practice, regardless of the dimension or where he works or she works in the SUS, but the content of their practice. And now I'd like to draw attention for what Kelly was talking, which is nurture and food. If we remember this, one of the principles of the food guide that we have in the first and especially in the second edition. It's the fact that there is no adequate diet if we don't have sustainable dietary systems that will produce healthy food. That is at the core. That is one of the pillars of our profession, and it is a pillar in our everyday life as well, especially in primary healthcare. Let's think how the sustainability is present when we have a group of users or and community work, how the sustainability issue is present when we talk, in our perspective, in our diagnosis. Very likely a lot less than we should have. So that is a topic that we have to think about, the issue of sustainability and the climate change as well in all aspects of our lives and consequently in diets as well. Our structure is still very precarious and the practices is still lacking. And we have elements that are very strong to try and revert the situation and to base our practice on a different paradigm. For example, at the beginning of 2019, we had the publication of the Lancet report about this global situation. And what is the text of the SIDME? And nowadays we have two main challenges.
Que é a questão da desnutrição e da fome. Relativamente mais.
And another one that is more recent, that is the issue of the obesity and the weight and the climate change as well, that is relatively recent as well. These three different crises and challenges, they are connected, and their consequences are much stronger than their parts. And what is determining aspect? These are the food systems and the agro-industrial complex that Mayara mentioned about the devastation of the ecosystem and the greenhouse effect gases. That is the basis of the SIDME.
Indicam que tamanho o nosso desafio e tamanha a urgência de nós superarmos
it's so urgent for us to overcome these challenges, and because the planet will survive. We are not going to be the ones that survive. There are millions of years in which the planet can regenerate, but we cannot. So what are the best systems, guidelines that are considered? We have to think about this aspect. We have to change in the way we behave in food and diets, and how we fight obesity, and we have to prevent or to fight and prevent the other forms of malnutrition, such as poor nutrition and lack of nutrition and nutrients, and then we're going to take care of the planet. We have to do it at the same time. The more articulated are these situations, these actions, the better the result will be. So we can think about this at a very macro level in terms of big public policies, for example, and how PNAE articulates in terms of to these issues. When PNAE was published or was written up, the climate change issue was specifically had some importance from the perspective of public policies and the evidence as well. But PNAE also looked at the actions that in an articulated manner. How do we align the climate situation with this? We also have to look at it from in the local perspective. When you are in this territory, how do I focus these three different problems that are there facing us, and in a way that is articulated, and how when I have a group work, when I go to the field work, when I go to people's houses to see how they live, to check how they live. How do I use these 3D glasses to see how the practices in life and the nutrition and dietary practices, how they impact in the healthcare of and health of people and health of the planet, and how, starting by very basic guidelines in everyday lives, we can coordinate these three main challenges in this specific territory. So there is something that we have, this experience we've been building up, and many experiences that we heard here are connected to this, but we have to do this, we have to make this something common and not the exception. Another aspect that I want to raise, highlighting a lot of what Kelly mentioned about the material of the matrix and the material of the diagnosis in food insecurity, we are, or we are now, or we are, and it's hard to choose the correct verb, a country that is going crisis that is very deep, and consequently, we're a country that is going hungry.
Everyone knows the data for food insecurity from the last research from the network. For this research from sovereignty, we have more than half of our population with some kind of level of food insecurity. And where does this insecurity goes through? It goes through the network of social assistance, but also steps on in some territories, first in the health system, in the unit or the health team, family health team, like Kelly said. And most of the time, these professionals feel that they are impotent facing a situation like this one, because logically, this issue is a consequence of issues that are so structural in our society that I look at myself as a professional, health professional, I conclude that I have not much to do, but we have a lot to do through what the matrix points out and from what the document for the diagnosis of food insecurity points out, which is a procedure to recognize this problem, take this problem also for you in the sense of saying this is a problem that health needs to contribute itself for the solution and begin procedures which will perform themselves and be applied in their articulation, territorial articulation. And this articulation goes through the tools for public policy, through the equipment for the schools, and also through the equipments and the structures itself and procedures that the community has. So for the small commerce, the person that has this agriculture, small agriculture land. So how can we bring to this person that knocks at the door from the unit and most of the time is very hungry, like many we see a lot of the time in the beginning of this year, and I can do it alongside of this person, look for paths not to solve completely because there are many procedures that interfere in this reality, but I can notice and feel that I am contributing for the evolution of the situation. And this will only happen when the challenge of intersectoriality in the territorial level will be surpassed very slowly. So that I believe that intersectoriality is a challenge from the federal level to the micro-local level. But it demonstrates our capacity to understand this paths, the systemic level, and to understand that they can be faced and surpassed through an action that is multi-professional, intersectorial, and articulated with society itself where the unit is being placed at. I finish here to give an opportunity for us to have a dialogue with those who are watching, and I thank for the invitation once more. Elisabetta, thank you very much for your speech and to bring elements which are very important for our reflection. Many are the people who are congratulating you in this chat and about talking about the richness of this speech. And so after these speeches, I'm going to pass the questions that were done in the chat. The first one I'm going to pass for Mayara Floss. Mayara, what's the concept of planetary health is connected to One Health, the triad environment, animal, and human beings? And for Kelly, which instrument the health units or family health units can use to identify cases of food insecurity in the population, especially in pregnant women and children? Another question for Kelly, is it fundamental to create a technical chamber of food and nutrition in APS so that the managers from SUS discuss the system and how to perform actions in health in order to not surpass a line between assistance, health assistant, and social assistants? Mayara, if you'd like to begin. So they sent the question and now I decided to bring this image. I would just like to comment here. I think the speeches from the other lecturers, Elisabetta brought an aspect that I would like to talk about, which is this endemic. Thank you very much for bringing this aspect. I kind of got lost in my speech. I think this is one thing that we need to think about, a synergy of pandemics, epidemics. When we think about the concept of global syndemic, it is fundamental, the issue of food systems in this. And I think that Kelly brings many tools for us to operationalize this in the healthcare. I thank for this table and all your speeches. I brought this image because it is very easy to understand. I don't know who asked, I don't remember, but I was reading the question. So we have an individual here, then we have public health, which will look for groups of individuals. The global one, we look with a focus in the disease, but we look for things that are more global, like the name says, HIV, malaria. So they're going to deal with these themes. The unified health, one health, we look for the human beings of the planet. About the issues of the interface, the issue of health from veterinary medicine, the health of animals with the interaction with humans, but it cannot look for the health systems, planetary health systems, for the planetary the system. So to look at this cycle of the nitrogen, to the cycle of phosphorus, look at the planet with more, it is one step further in relation to this. I don't think that they are, sometimes would say that, oh, I don't like the planetary health, I only want one health. I think this is not the point of this question. It's just to clarify and bring what this doubt. But these are concepts and they have a synergy, so they work alongside each other. This is not an opposition. It's not one in one side and one in the other. We just like to make it clear and specified for those who are watching. I don't know if it's clear for the person who asked me. I'm just answer me if I answered it correctly. Thank you, Mayara. Now, Kelly, please. Hello, about the question from the tools and to identify food and nutritional insecurity in the APS. Gabriela already put here in the chat the links for the materials that were developed within this context of the pandemic. It was very latent, the necessity to have tools to support the teams. And talking about this context of the pandemic, when we were analyzing the works, the written works in the APS Forte Prize, how many works they had from reports of experiences from the teams of primary care, mobilizing the other social equipments from the territory, private sector to be able to mitigate food and nutritional insecurity, the situation of food from families in their territory. So with this comment, I now begin to answer the question about how to do actions, not surpass the limit between the health assistance actions and social action care. So the territory is going to say what the team is going to do. So how we saw in our presentation, so the coverage of the social attention and health attention is still very small for the size of our country. These services, they meet the necessities of the families in greater vulnerability risk, those who are in the in this registry for social assistance, and maybe they cannot handle it sometimes. They cannot handle the necessities of the municipalities. We have municipalities with, they do not have CREA, CRAS, so the capillarity of our system for the assistance, social assistance needs to increase. So within a territory, the primary healthcare team does not have this service to articulate this. This is, for example, in a secretariat for social assistance. I do not see a problem for professionals in the primary healthcare to have the power, be empowered with certain information related to programs and strategies for social assistance, which can be given to the population in the territory. I had an experience, it's even in my curriculum. I did a course to disseminate social prevalence because the management of the municipality understood that all of us from NACI had to understand the difference between the benefits that we receive from INSS, because this is what the families would talk about with us when we did collective activities, the house visits. How am I going there to do an activity? This is the doubt that arose in the group with the population or the family, and I did not know what was the difference, the orientations, the minimum orientation so for those users. So we all did this course as a technician from INSS and professionals from NACE to be able to orient the population with this context that was necessary. It was great because I even oriented my family and the people, and well, as a citizen, it was very enriching for me to understand how the social assistance works, about the retirement. This will depend on the territory, the management of the schools, that's municipality. Things are centered in the secretariat of, there are social assistance services which are not centered in the territory. So I do not think that we need to have defined a place that separates social assistance from health. I think that in the norms that say which are the responsibilities from primary care and the reference centers are already there clear which are these functions. But I always like to remember that the necessity there with the use of the territory makes us design other trajectories which are not always in the protocols. We need to be open to construct these paths. I'm not talking about doing something irregular or illicit, but sometimes the protocols do not foresee all the situations. So you need to have flexibility to build these bridges, these networks, to guarantee the rights of the population that you are responsible for. And the other question, which was about the creation of a technical chamber of food and nutrition in the APS, so that the managers from SUS can discuss these issues. It's not clear if what is the idea of the locus of this technical chamber. I would think that it would be very interesting to have this type of technical chamber within CONAI, CONASEMES. I think that it would be very good that they have a dedication to this theme like there is in technical chambers of pharmaceutical assistance, for the health of the woman and children, for chronic diseases. I think it would be very interesting to have in the councils of for secretaries, municipal and state secretaries, a technical chamber with this objective. I think I answered you all. Excellent. Thank you very much. To finish this table, now I'm going to invite our lecturers to finish in with a comment. Now we can begin by Miss Elisabetta, and then if you want to do some comments, Elisabetta, about these questions, your speech, and then we're going to go back to Mayara and then Kelly. Thank you. I would like to make a comment actually that I did in my initial speech, which is about the importance of the matrix and that instruction about food security that put about the environment, the food environment. Most of the times, the issue of the food environment is very strong. It has many researchers and etc. So for those who are working in the local level, the territory, it's important to know that the food environment is where the person, the individual and communities will find this food system, and it's how the food system expresses itself in people's lives. So how does this happen? It is these networks, what happens, resources networks, it is the price of food, the information that circulates, the values which are worked all the time, and it is within this that you can work on and act on to make right transformations within that day-to-day life in a very concrete way. So for example, when you articulate yourself with this network and start to think, no, I'm going to organize some fair. Yes, you will organize a fair and you will transform the food environment of that territory, of that community, and not only for the people who will buy eventually, but also for the workers, rural producers. So you create a circle, a profound circle that will help you as a health professional, because when there are more healthy foods that are circulating and being consumed, the more we're going to work only with promotion of health and we're not to be able to deal with diseases. Thank you very much. Well, I would like to do some comments, just finishing my speech there. While there is a plastic cups in the universe of health, you're still having a problem. It may seem like, oh, we're going to talk about garbage. No, I'm going to talk about water. Why? If everybody who is hearing now may even think about the use of plastic cups, pre-pandemic and the actions that could happen anywhere there, and there will be water there and many plastic cups. That means that the unified health system is leaving a gift for the planet of at least 500 years of that meeting to discuss that theme of health, or maybe of that day, the user who is using this plastic cup. So I think that it's very important from the actions which are organizational for the unit in relation to the responsibilization with the residue and separation of the residue. It is possible to clean these cups. It's possible or offer this within the units in a way that is not bad for the environment. You can even remember for us for years. And I would like to use the example of a birthday party, which is where we most of the times we see many problems of those very traditional one, the brigadeiro, which is a Brazilian food, which is ultra processed. It is inside on top of a plastic thing, and then which is on top of a thing of paper, and then which is on top of another place of paper with, I don't know, plastic again. So we are producing a lot of garbage. We only want food, and then but many of the things that are processed, ultra processed, they are in these packages, and this is a very important issue with sustainability. So we can bring this to our talks. This is not separate talks. We cannot create silos in this. So we need to have this space. This issue it does not bring with separated. Not going to talk only about food. We need to talk about garbage, littering, and talk about the community, food. So this is all together. We can do the transdisciplinarity of these discussions. And just for us to think very fast here, the issue of the rural, we are talking about this urban space. We have the units, rural units, that we need to think about the specificities of these communities. This is going to stay for our next debate, but I just would like to just say the importance of this issue here. I thank for the participation here. I'm very happy to have participated here. It was very nice to know Elisabetta, Kelly, Milena, and congratulations for the event. Once again, thank you very much. Can I go now, Milena? It is a pity that it's just a small time to talk. I am missing the agglomeration of people. I would like to speak with you in the present way, but this is what I have for now. So I'm going to take the opportunity to comment about an issue that always when Segan does these debates, it is a thing that is, people talk a lot in the chat. So people, they ask for nutritionists, dietitians, and other services. Now we were talking about social assistance. There are people that are talking, oh, we need to have dietitians there. I would like to finish my speech asking for us to reflect more about the role of the dietitian, the competences and the capacities of this professional in these services for primary attention, healthcare attention. I am a dietitian. I'm not against the category. I already did. I was an APS dietitian. We have many friends that work there. And within this experience, it is very clear for me that it's not to include dietitians mandatorily in the teams that we're going to solve the food systems of the population. We have knowledge, abilities, technical abilities. We can be, like we say, protagonist, inductor, and qualifier of practices, but we are not capable to solve all problems by ourselves. So here, I think that our mantra needs to be the defense of the multi-professional team. We need the physical therapist, the psychologist, the physical educator. We need the professional of the community agent to stay in our country, that it does not end. So we are going to go stronger. We will be able to have a nutritional attention, which is more qualified within APS if we defend a multi-professional team and do not stay only spending the energy and asking for the inclusion of the dietitian, because by themselves in a territory which is very complex with many social vulnerabilities and demand, and the manager asking for them to stay in the office benefit to the population. And so now I finished my contribution for this debate and stay here available for you to continue in the next opportunities. So the rest of good, have a good seminar.
Kelly, Mayara, Elizabeth, thank you very much for this moment, for your proposals and your comments. On behalf of the General Coordination of Nutrition and Food and of the Ministry of Health, I thank the presence of everyone and say that we were going to have a 10-minute break, and after that, we're going to talk about national and international experiences on nutrition in the context of primary health care. If you haven't contributed by elaborating the second letter of Brasilia, go to the website and leave your reflections. Thank you very much and see you soon. Thank you very much. Congratulations. Thank you. Bye-bye.
A gente planta reflorestando, né? Produz reflorestando. A finalidade é de ter uma alimentação mais saudável. É uma forma de plantar, de produzir agroecologicamente, então assim, com a ajuda da natureza. Então o alimento ele vem muito mais que saudável, né? A gente procura conciliar a natureza com a produção e deixar que a natureza haja. Então a finalidade mesmo é essa, é estar contribuindo aí com o meio ambiente, com a natureza, um alimento muito mais saudável. O trabalho é bem intenso, né? Na segunda-feira a gente está tirando aí para fazer os plantios, geralmente os manejos da agrofloresta, porque tem manejo de poda, limpeza de canteiros. E na sexta-feira é a nossa colheita, né, para a CSA. A gente colhe durante o dia na sexta-feira. No sábado, a gente entrega as cestas num ponto de convivência. Nós entramos aqui nessa área em 2011, que era uma área degradada, um monocultivo de eucalipto. O solo totalmente degradado, ácido e tal, era considerado como flona, em cima da bacia do descoberto. Hoje, o nosso trabalho aqui, cuidar desse solo, né, voltar o cerrado, então assim, vai um alimento natural mesmo, com todos os seus nutrientes, sem nenhum defensivozinho para causar mal à saúde. A gente contribui com o pessoal da cidade. Então, assim, é toda essa cadeia, a natureza, a comunidade, a população e a minha família. Isso é gratificante. É você poder construir e contribuir para toda essa cadeia, uma cadeia alimentar, né, que está aí alimentando todo mundo, e saudavelmente. E quem tiver interesse é só vir, dar as mãos para que a gente possa fazer isso ficar muito maior, né? Que isso generalize mesmo, né?
Saúde Brasil apresenta 5 dicas para aproveitar os alimentos e evitar desperdícios. Algumas partes dos alimentos que são descartadas no preparo das refeições podem ser aproveitadas. Não se deixe levar pelas aparências. Vou te dar 5 dicas para aproveitar melhor os alimentos. Dica 1. Procure usar todas as partes que um alimento tem para oferecer. Não despreze nada que possa ser aproveitado. Dica 2. Cascas, talos e até as sementes têm grandes quantidades de vitaminas, minerais, fibras e nutrientes essenciais para a saúde e para prevenir doenças. Dica 3. As cascas das frutas podem fazer parte de receitas bem saborosas. Receitas deliciosas e nutritivas não faltam. Dica 4. Sementes podem virar farinha para vários pratos ou serem incluídas em pequenas refeições. Dica 5. No site do Saúde Brasil você encontra receitas saborosas de culinária sustentável. Aproveitar alimentos é bom para o seu paladar, para o seu bolso e para o meio ambiente. Quer mais dicas? Acesse o site do Saúde Brasil. Saúde Brasil apresenta 5 dicas para preparar o café da manhã. Para muita gente, o café da manhã é a parte mais gostosa do dia. E com os alimentos e combinações certas, dá para ser mais saudável também. Olha só essas 5 dicas. Dica 1. Dê preferência aos alimentos in natura ou minimamente processados. Existe uma variedade enorme para você escolher. Dica 2. É possível fazer diversas combinações usando alimentos de grupos diferentes, como o grupo das frutas, dos cereais e das raízes e tubérculos, por exemplo. Dica 3. Uma alimentação adequada e saudável valoriza os alimentos e as preparações culinárias típicas de cada região. Dica 4. Diversifique aromas, sabores, cores e texturas. Além de ficar um café da manhã bonito, que agrada aos mais diversos paladares, você terá uma maior variedade de vitaminas e minerais. Dica 5. Acostume-se ao sabor natural do café, dos sucos e chás e evite a adição de açúcar. Se for usar no preparo de alimentos, use com moderação para que a alimentação não fique desbalanceada nutricionalmente. O consumo excessivo de açúcar aumenta o risco de cárie dental, de obesidade e de várias outras doenças crônicas. E anote aí, um dia mais feliz começa com um café da manhã saudável. Para saber mais, acesse o site www.gov.br/saúde/Saúde Brasil.
Quando a gente fala de comida brasileira, você pensa em quê? Qual é o prato que é a cara do Brasil? É bem difícil competir com ela, não é verdade? A feijoada é só uma das incontáveis receitas que a gente faz com o grão mais famoso do país. Popular na mesa, popular no campo. O feijão é reconhecido pela fartura das colheitas e por se adaptar facilmente a qualquer clima do Brasil. Aqui no Brasil, que é conhecido internacionalmente pela sua vocação em alimentar o mundo, o feijão é rei, soberano de norte a sul. Carioquinha, preto, branco, verde, de corda. Ele é do baião de dois. É tropeiro e é acarajé. É tutu, bolinho e dobradinha. E falando em dobradinha, tem coisa mais brasileira que essa dupla aqui. Tem conforto maior que um caldinho dele, bem temperado, para abrir o apetite. Ele está no prato principal, na salada, e tem gente que faz até doce com ele. Feijão é família reunida. É como sempre disse minha mãe, é substância. Rico em ferro, cálcio, potássio. Ele combate a anemia e reduz o colesterol ruim. Um bom feijãozinho faz bem pro coração. Eu tô falando literalmente. É uma leguminosa rica em proteínas, que também previne o câncer e melhora a saúde intestinal. É só ouvir esse apitinho que a gente sabe que a felicidade está ficando pronta. Feijão é samba no sábado, é a casa da avó no domingo. E para milhões de brasileiros, feijão não é só alimento, ele é afeto. E como dizia o poeta, feijão tem gosto de festa. É a hora da alegria compartilhada, da comida de verdade.
que a alimentação saudável não esteja na ordem do dia ou não seja falada. Ela é falada, mas o problema são as fontes. O nosso ambiente não é propício para uma alimentação saudável. É o que a gente chama de um ambiente obesogênico. Esses apelos comerciais são os grandes obstáculos que a gente encontra. Mas não é só isso, não. Tem muita gente que fala sobre alimentação saudável, mas sem propriedade. A busca de um corpo bonito, esteticamente adequado, ela pode estar permeada de mensagens inadequadas. Então você tem nas mídias sociais pessoas que falam que para conquistar um corpo bonito, esbelto, magro e feliz, através de uma dieta da moda, de uma solução fácil, a pessoa esconde todo o cotidiano, esse ambiente inadequado e obesogênico, e traz uma solução milagrosa. Se você for olhar esse conteúdo, ele é sensacionalista e ele não é saudável. E para você romper isso, você tem que aprender sobre alimentação e num universo que é muito desfavorável, fazer a escolha mais adequada.
Infelizmente, os alimentos ultraprocessados estão com uma oferta muito maior aí na vida das pessoas, nas cidades. Como evitar isso? Ao invés de ir fazer compras em locais cuja oferta é expressiva desses alimentos ultraprocessados, dê preferência de ir em feiras livres, mercados locais, açougues, mercearias, em que você vai ter uma oferta maior de alimentos in natura e minimamente processados. A outra dica é, quer comer comida de verdade? Faz uma lista de compras dos alimentos, que aí você vai fazer a sua compra mais focado e garantir saúde. Muita gente acredita ainda que a alimentação saudável é mais cara, mas não, a gente precisa mudar essa visão. Existem certos momentos do ano em que você vai ter uma maior produção de determinado alimento in natura ou minimamente processado. E aí, por ter uma maior produção, a gente vai ter um custo mais acessível para a população. Outro aspecto é o local de compra desse alimento. Então, se você vai numa feira, você vai ter também um acesso melhor desses alimentos no que diz respeito ao seu custo. Você estreita a relação entre consumidor e produtor. A distância percorrida desse alimento é mais curta, que até são chamados circuitos curtos. Para manter uma alimentação adequada e saudável, mesmo comendo fora de casa, o que nós podemos fazer? Você pode ir num restaurante que venda comida por quilo, ao invés de ir naquele fast food. No restaurante de comida por quilo, você vai ter uma maior variedade de alimentos saudáveis. Outra opção também é você preparar a sua alimentação em casa e levar para onde você tiver que ir, seja o trabalho, escola, faculdade ou outros espaços que você vai ter que ficar fora de casa.
O Guia Alimentar para a População Brasileira, publicado pelo Ministério da Saúde em 2014, ele nos trouxe uma regra de ouro: preferir os alimentos in natura e minimamente processados e as preparações culinárias, ao invés dos alimentos ultraprocessados.
Boa tarde a todas e todos. Bem-vindos.
Good afternoon, ladies and gentlemen. I'm Ana Carolina Lucena. I'm a nutritionist and I work at the National Coordination of the Ministry of Healthcare in Brazil. And I will conduct the international panel of national and international experiences of the second day of seminar, the International Seminar of Nutrition and Primary Healthcare. In this round of presentations or introductions, we have the actions and perspective of the policies on nutrition and emphasis in the primary healthcare and at the end of the presentations, Mr. Antonio Leopoldo, representative of the Department of Family Health Care of the Ministry of Healthcare, will make some comments, and after that we'll have the registries or the comments in the chat. The first international experience will be the one from Canada, and it will have two different parts. First, we're going to have the presentation of Dr. Ximena Ramos Salas, a doctor in public health care and specialist in social behavioral sciences by the Universities of Alberta in Canada. Currently, Dr. Salas works as a consultant of obesity in the European Association for the Study of Obesity and the World Health Organization. She will talk about the Canadian guidelines of clinical practice for the handling of obesity in adult people. And after that, we're going to have Dr. Elena Piccinini Maniz, a doctor and PhD by the Western University, and associate professor in family healthcare and working in obstetrician in the University of Dalhousie, and director of family healthcare at the University of Dalhousie, and a team leader or research leader in the Health Center of the IWK in Halifax, and she will talk about the 5 A's. Dr. Salas, thank you very much. You'll have 15 minutes, and when you get closer to the end, 5 minutes before, we'll let you know.
Thank you very much for that introduction. Can you see my screen? Perfect.
Yes.
Perfect. So thank you so much. So I'm just going to take a few minutes just to give a little bit of overview of the Canadian Clinical Practice Guidelines, but then I will pass it on to Dr. Piccinini Maniz, who will review the 5 A's of obesity management. So thank you again for inviting Obesity Canada to participate in this seminar. For those of you who are not familiar with Obesity Canada is a national registered charity representing healthcare professionals, researchers, trainees, and students working in the field of obesity, as well as individuals living with obesity. Obesity Canada's vision is a day when people living with obesity are understood, respected, and living healthy lives. Our mission is to improve the lives of Canadians living with obesity through obesity research, education, and advocacy. And we have 3 strategic priorities, which are to address the social stigma associated with obesity and changing the way that policymakers and healthcare professionals approach obesity and improving access to evidence-based prevention and treatment. So in August of 2020, through a collaboration with Obesity Canada and the Canadian Association of Bariatric Physicians and Surgeons, Canada launched new clinical practice guidelines for the management of obesity in adults. The guideline development process was quite comprehensive, involving over 60 Canadian experts, patients living with obesity, engagement of Indigenous communities, and healthcare professionals who work in primary care. We used a collaboration with an independent methods expert team at McMaster University, who helped us implement a systematic review of the literature and to develop recommendations based on the GRADE methodology. The final guideline included 19 chapters and 80 recommendations covering a broad range of topics in obesity. The target audiences were primary care healthcare professionals, people living with obesity, and policymakers. So as you can see from this slide, Obesity Canada is working towards dissemination and implementation of the new guidelines. And even though the Canadian guidelines were launched just months into the COVID pandemic, the guideline was the #1 read article in the Canadian Medical Association Journal in 2020. We had over 85 million media impressions during the launch week of the guidelines, with over 300 media articles in local, national, and international media. Since we launched the guidelines, we've reached over 45,000 healthcare professionals through webinars and education conferences. And we continue to receive continuous visits to our website where people are reading the guidelines and downloading implementation resources. So when we launched the guidelines, many countries approached Obesity Canada to see if it would be possible to adapt the Canadian guideline for their country. We are therefore currently implementing a pilot project to assess the feasibility of adapting the Canadian guidelines in 2 countries, Chile and Ireland. And we expect that Chile and Ireland will launch their adapted clinical practice guidelines in the summer of this year. So what's new in the clinical practice guidelines from Canada? Well, first of all, I should say that the guidelines are framed using a chronic disease management model, and it summarizes all the evidence-based treatments that are available in Canada. A key message in this guideline is that Canadians living with obesity and all individuals living with obesity should be supported using evidence-based resources and long-term support that moves beyond simplistic strategies such as advising individuals to eat less and move more. A fundamental change in the guideline is the new obesity definition that would allow clinicians and healthcare providers to distinguish between body size and the disease of obesity. The objective was really to make it very clear that not all individuals who have an elevated BMI or body mass index have obesity, and that to be able to diagnose obesity, a full medical assessment needs to be conducted. Obesity is therefore defined as a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal or excessive body fat that impairs health. And the key word in this definition is the word impair. This means that if a person's body fat is not affecting their health, they do not have obesity. And to be very clear, this guideline includes specific recommendations for the management of obesity, the disease of obesity, and may not be applicable or appropriate for people who have higher weights and that do not have health impairments from their weight. So like any other chronic disease management model, such as for diabetes or hypertension or cancer, nutrition and physical activity intervention should be provided in combination with adjunctive obesity-specific treatments that can be tailored to meet an individual's health and weight-related outcomes. So the guideline recommends that people living with obesity should have access to medical nutrition therapy, physical activity interventions in combination with the 3 adjunctive obesity treatments, which are psychological and behavioral interventions, pharmacotherapy, and bariatric surgery. The Canadian guidelines are framed using the 5 A's of obesity management, which Dr. Piccinini-Valles will review in a moment. The 5 A's stand for ask, assess, advise, agree, and assist. The first step is to ask patients for permission to discuss obesity. We ask that healthcare professionals consider that many patients have experienced a lot of weight bias and biased treatment in the healthcare system, and that this may affect their relationship and communications with healthcare providers. Therefore, healthcare providers should approach the discussion about obesity in a non-judgmental manner, and if the person is not ready to discuss their obesity, to offer patients some resources about obesity and to extend an open opportunity to reassess this in the future. Once permission has been secured and a full medical assessment has been completed, healthcare professionals can then move to the 3rd and 4th steps, which are to discuss and agree on evidence-based treatments with the patient. And the final step is to assist the patient to find and access support that they need to arrange a follow-up with the patient. Since obesity is a chronic disease, long-term follow-up with the patient is essential, as the treatment will need to be lifelong. And finally, the guidelines conclude that the focus of any chronic disease treatment, including obesity treatment, should be to improve health and well-being, not just reducing the numbers on this scale. And with that, I'm going to pass it over to Dr. Piccinini-Valles, who is going to go through the 5 A's of obesity management in more detail. Thank you.
Muito obrigada, doutora Salas. Agora eu passo a palavra para
Thank you, Dr. Salas. Now I'm going to pass the floor to Dr. Piccinini-Valles that will also have 15 minutes. Thank you very much. Welcome, Dr. Piccinini.
Confirm. Oh, so we're starting from 15 again. Okay, thank you. All right. So thanks, Jimena, and thank you so much for the organizers of the seminar. I am a family physician and a PhD clinician researcher in Canada. My area of research is actually mostly around issues pertaining to weight gain and pregnancy. Sorry, I'm trying to get the move ahead button here. There we go. However, today I'm going to be talking to you about the 5 A's of obesity management, a tool launched in 2012 by Obesity Canada. This tool is actually developed based on principles of patient-centeredness and behavior change theory, and is intended to be a point-of-care tool for practitioners interested in addressing obesity with their patients. So to start, I have no conflicts of interest. And I have to say, I wish I'd known that this was going to be in Portuguese, because I might have been able to try to translate. Eu falo pouco de português, mas não o suficiente para falar com vocês em português. So I'm sorry. Anyway, maybe next time. So I'm zooming in from Halifax, which is a city on the east coast of Canada. And like many other places, we're experiencing the effects of climate change. So in my city a few days ago, we had a high of 12 degrees, and today we're back down to a wind chill of -15. And also, like many other countries, we in Canada have been seeing a shift in the demographics of our population, in which the BMI of the population is increasing. And you will notice a trend in Canada for the population's BMI to increase from west to east. So where I live specifically, over a third of the population has obesity. So for me as a family physician, that means that a large proportion of the patients that I see have obesity and comorbidities. And you would think that by now we would be addressing obesity just like we address any other issue in our practices. But the reality is that in Canada, at least, obesity is infrequently addressed in primary care. So enter the 5 A's of obesity management, a tool which incidentally has been adapted to both the pregnant population as the 5 A's of healthy pregnancy weight gain on the bottom left of your screen, and also to the pediatric population as the 5 A's of pediatric obesity management on the bottom right of your screen. The 5 A's has 5 key principles, and I'm going to review those with you one by one. So the first key principle is that obesity is a chronic disease. It's a chronic condition. Jimena spoke about that a few minutes ago, so I don't need to repeat it all, other than to say that obesity should be treated just like hypertension or diabetes, and that short-term fixes that focus only on weight loss are not usually successful. In Canada, not all provinces recognize obesity as a chronic disease. So for family physicians, such as myself, recognition is actually key because it impacts on the way we bill for encounters with patients. It impacts on our ability to advocate for resources and coverage of medication, and also in the way that we organize our care. The second key principle is that, again, as Jimena mentioned, obesity management should be about improving health and well-being and not simply reducing the numbers on the scale. This point was really, really emphasized in the 2020 Canadian guidelines that Jimena spoke about. The third key principle is that early intervention means that root causes of obesity need to be identified and addressed, and roadblocks need to be removed. All too often, we make assumptions that people with obesity are not physically active and are not eating a healthy diet, and we must not make those assumptions. The fourth key principle is that success will be different for every individual, as a person's readiness and capacity to manage their weight will differ. Also, success can be measured in a range of ways, again, varying from individual to individual. And then finally, the last key principle is about understanding and accepting that a person's best weight may never be an ideal weight, and rather setting realistic targets that help a patient best approximate their ideal weight and sustain it while enjoying the benefits of improved health is the most beneficial approach. So here are the 5 A's. Although I've listed them in order, and I will review them in order, it's important to note that these tasks are not meant to be sequential. There's an iterative element to this, with the exception of the ask and the initial assess. And it'll become clear in a minute why. So the first A is ask. Now, this isn't the same ask as you might be familiar with, for example, in smoking cessation, in which we ask if the patient is concerned about their smoking. No, here the ask is about asking permission to even start a conversation about obesity. This behavior on the part of the clinician is respectful and gives power to the patient to control how things progress. It's really, really important not to skip this step, as failure to do so and just jumping right into a conversation about weight might result in a very uncomfortable situation for the patient and ultimately also for the provider. We have to accept that a patient might not be ready to have a discussion about their weight on a particular day. The second A is assess. This is when the provider should be asking lots of questions in order to understand the patient's context and the journey of their weight. It's a reminder for us as clinicians to never make assumptions, as again, people with obesity might be already undertaking healthy behaviors, and there are so many reasons why someone might struggle with weight management. We should be looking for the drivers of obesity, mentioned here as the mental, mechanical, metabolic, and monetary, and also trying to understand the root causes of weight gain as shown in this slide. So is a person's weight gain due to slow metabolism? Is it due to increased food intake or to reduced ability to do activity? I like to show this following slide, which is known as the spaghetti diagram of obesity. And it illustrates the complexity of causes and drivers of obesity and reminds us that we should not be making assumptions. I'm repeating myself, but it's so important not to make assumptions. We need to ask questions in order to understand the patient's context. And if we zoom into parts of this spaghetti diagram, we're talking about, an individual's physical activity. So what kind of parental modeling of physical activity did they have? What learned activity patterns in childhood did they have? How safe is their neighborhood to undertake physical activity? We might be talking about individual psychology, so their self-esteem, their exposure to food advertising, perceived lack of time, and their food literacy, which is so important. And we might be talking about issues pertaining to food consumption. Again, there's so many reasons why someone might struggle with weight management. I sometimes challenge learners working with me not to make any statements at this stage, at this assess stage. Everything that comes out of their mouths should be a question. For any clinicians in the audience, try that sometime. It's not as easy as it sounds. The third A is advise. It's logical that only after the practitioner goes through the first two A's that this step can really take place. It's very difficult to make meaningful recommendations to someone if you don't understand their context. And depending on the patient, you might be making recommendations on sleep, time, and stress. You might be making recommendations on dietary intervention, on physical activity, on psychological issues, low-calorie diets, medications, or bariatric surgery. Again, the focus, as Jimena mentioned, and I'm mentioning over and over, should be on improving health and well-being rather than simply losing weight. I'm just going to minimize you guys. There we go. The fourth A is agree. This is about finding common ground, agreeing on the roles of the patient and the provider, managing expectations, and coming up with a plan that has SMART goals. In English, SMART is an acronym for specific, measurable, achievable, rewarding, and timely goals. And then finally, the fifth A is assist. And this is where the provider helps the patient find credible and evidence-based resources. And there's some evidence that an interdisciplinary team approach is helpful. And I understand that in Brazil, the SUS is really developing with many healthcare professionals around the table, which is fantastic. But at minimum, continued support in the form of follow-up is really necessary and ideal, as that's where the patient-centered relationship, the patient-provider relationship that's formed has been shown to be associated with positive outcomes and is so important. I just wanted to review some evidence for the use of the 5 A's of obesity management. So there's been some work, and for example, this was a pre and post study that was conducted in primary care clinics in Canada. 25 providers received a 90-minute session on training in the 5 A's of obesity management. And the researchers found that implementation of this tool resulted in a 2-fold increase in the number of patients reporting a conversation about weight management with their provider. And we know from other work around the world that having these conversations, just having these conversations, increases the odds that a patient will at least try to initiate a behavior. In an RCT that we conducted here in my city with pregnant women, so we use the 5 A's of healthy pregnancy weight gain, we didn't find any difference in perceived patient-centeredness when discussing gestational weight gain. We didn't find any difference in self-efficacy to manage gestational weight gain or readiness to adhere to gestational weight gain guidelines, et cetera. And we think that that might have been in part due to the fact that we really struggled to measure the provider adherence to the training in the tool that we provided. Then in this mixed methods study published in 2017, training in the use of the 5 A's of obesity management was associated with improved GP, so this was in the UK, so GP confidence and self-efficacy in managing obesity. And then finally, in this very recently published RCT, training in the use of the 5 A's of obesity management improved physician-patient communication and patient motivation, again, alluding to what I was talking about for an earlier study. However, as a standalone tool, it didn't improve weight management in the long term. So clearly there's some more work to be done in this area, but we believe that this is a tool that can help. That concludes my presentation, and I thank you very much for listening. Muito obrigada pela sua atenção.
Muito obrigada, doutora Pitinini Valis.
Thank you very much, Dr. Helena. Thank you, Dr. Salas, for this presentation from Canada. Dr. Pitinini, your Portuguese was very well received by us, and I remember you all that who not contributed with the construction of the second letter from Brasilia, that your participation is fundamental. Just access this website and click in the second letter from Brasilia, Segunda Carta de Brasília, and confer this material launched in the seminar, the matrix for the organization of the food in primary health care, and the recommendations to strengthen the attention to nutrition in APS beyond the launch of the products elaborated in partnership between the General Coordination of Food and Nutrition from the Ministry of Health and ABIREMI, the window of knowledge for public health nutrition, and the map of evidences about interventions and treatments for the maintenance in the APS. So now, continuing our program, we are going to have the presentation from the experience from United Kingdom with the first exposure done by Mr. James Blackshaw, dietitian, graduated with the distinction in the Imperial College of London, master's degree in public policies of health, and celebrated with a medal in Nutrition Society in 2015 in reconnaissance of this excellence in public health. So this I leaderate the team of healthy, and it's responsible to work with the theme of the environment of health. This presentation will be about the approach of obesity. Then we're going to have Dr. Rosetta West, senior professor from London South Bank University and nurse in the NHS. It acts in the emphasis of education for the sustainable development in public health, taking care of diabetes, nursing, and clinical nursing. Dr. Rosetta collaborates internationally with the University of Occidental Indies, Trinidad and Tobago, and is Jamaica that will do its presentation about the care in diabetes. Dr. Blackshaw, welcome. You're going to have 15 minutes for your presentation, and when there's 5 minutes left, I'm going to tell you for you to conclude, okay? Now you can begin.
Thank you. Good afternoon, everybody. I'm just going to share my screen. Just put this on. Can you see the slides?
Yes, we can.
Okay, that's good.
But you're not in presenter view.
I'm not in presenter view.
No.
How about now?
Not yet, no. If you go to the top of your screen with PowerPoint and the slide view.
Yeah.
Well, we can see the slide. Oh, there you go. There you go.
Can you see that now? Okay.
We can, and we can see your notes too.
Thank you. Oh, you can see my notes. Thank you, Helena. So I'd just like to introduce my colleague, Emma, who's going to speak with me today. So Emma, do you want to just say hi?
Hi, everyone.
So we're doing a little double act here. So I'm going to give you a very quick overview of what is happening in England from a national perspective in terms of the actions that the government is putting in place to tackle the drivers of obesity, so poor diet, lack of sedentary lifestyles, and lack of physical activity, etc. So I'm going to quickly go through what we're doing at a national level. And then I'm going to talk a little bit about work that we've done in England to enable local authorities to put in place whole systems approaches to address the drivers of obesity. And then Emma's going to talk from a more local place-based perspective about the experience in Gateshead. So it's great to be here with you today. And I didn't manage to make much of the session today, but hopefully this will add some value to what other colleagues have presented today. I guess before I just start on this, I think that we all realise the extent of the situation that we're facing globally in terms of the drivers of obesity. In terms of the excess calories that are in the food system, and in this country, in England, most notably, we have great data and research, and around children, we have the National Child Measurement Programme, which measures children at the ages of 4 to 5 and 10 to 11. And from that data, and this is just a smaller sample than usual because of the pandemic, but I just wanted to give you a flavour of the impact that we've seen in this country of the pandemic and what everybody's been through. The rates of childhood obesity, so children living with obesity at the ages 4 to 5, have gone up from about 10% to 14.5% from 2019 to 2021. And in 10 to 11-year-olds, it's increased from 21% to 25.5%. So really big impact, I think it's fair to say, in terms of the pandemic. But there's been an unequal impact, so it hasn't affected the population equally, and so the gap between the children living with obesity in the least to most deprived has grown. So in this country, we have children living in the most deprived areas have twice likely to be living with obesity. And the reasons, well, the drivers of obesity, and this diagram shows quite clearly those drivers and those influences. This was work done back in 2007, and it's still lasted this long in terms of providing us with a great idea of the drivers, and they're multiple and they're linked, and so there are lots of feedback loops in terms of the impact of these factors, whether it's across the food system in terms of food production and food consumption, to societal influences, and obviously biology and the environment that people live in. This hasn't happened overnight. The drivers of obesity have been years in the making, and it's going to take us years to really put in place the actions to tackle some of these drivers, to make sure that we can support people living with obesity, but we can support the future generations of young people growing up, so that they have a healthier environment where the defaults are healthier food at the point of purchase. And we'll touch on some of the work that we're doing in this country to make that happen. But we've created this environment for ourselves in terms of our consumer behavior, and we've bred convenience in terms of the marketplace, and most of us are exposed to food and drink choices wherever we look, whether that's at home. You can get virtually anything delivered to your homes these days, and obviously the pandemic has exacerbated that in terms of home deliveries, whether that's your groceries but also fast food coming into the home as well. You don't actually have to move anywhere these days to get all of this food coming in. And when you go around your towns and your cities, then food is everywhere, isn't it? And it's digitally everywhere as well, whether that's on TV or on the internet. You can't get away from it. And we need action to deal with that. And very often these foods that are marketed and advertised are obviously high in fat, sugar, and or salt. And they're, you know, when you go to your takeaways, they're larger portions and full of calories. So it's no surprising that we've seen such an impact. But there is no single solution to tackling obesity, and we need preventative, and we need treatment options and obesity management options, which we've just heard Helena talking about from a Canadian perspective. But we also need actions at a national and a local level, and it's everybody's business to take responsibility for this. So at a national level, the government and the National Health Service in England have put lots of actions in place. So we have preventative action to try to improve the nutrient content of food so that we can deal with those foods high in fat, sugar and salt. And we've got a big reformulation program in this country that's been going for a number of years and made some success. We've had some success in terms of delivering legislation on the soft drinks industry levy to reduce the amount of sugar in fizzy drinks. But we've also introduced through healthcare, through primary care, but also local government, obesity management and weight management services to support people living with obesity, so that we can try to support and care for people. But that all needs to sit in this whole systems approach, and that's vital when we think about all of those drivers and exposures that we have, and particularly we need to support individuals who are living with excess weight, whether that's being overweight or living with obesity. But we need to make sure that for the future generation that we're putting in place the structures so that our environments, whether that's the places we live or the digital world that we all live in these days, is healthier, and that the options are healthier. But we also need to put in place action to enable local authorities and local government in this country, in England, to make their places healthier. And so at a national level, we can put things in place that will help to enable and amplify action at a local level. We all live in places, and we want those places to be the healthiest they can be to support us to make healthier options, whether that's being more physically active and leaving the car at home, or choosing the healthier foods options. And we need to break down the barriers, in particular in more deprived areas, because it's not an equal playing field. And so this work, we put in 5 years of work working with academics to really look at the evidence base and use systems science tools to enable local authorities to put a whole systems approach in place. I'm not going to go into the detail of this because Emma's going to give you a good reflections on how this felt locally. But needless to say, everything is available by on gov.uk, and we can forward the links for you to have a look at. So without further ado, I'm going to hand over to Emma.
Thanks, Jamie. I'm just going to give a perspective from a local authority. So I'll give you a little bit of background about myself. So I'm a programme lead. I work on healthy weight in public health in one of the councils in England. It's situated in the northeast, Gateshead, and we have a population of just over 200,000. In terms of deprivation, Gateshead is one of the 47th most deprived local authorities out of 331 in England. So we've got huge challenges in terms of deprivation, with over 30% of our residents living in the 20% most deprived areas in Gateshead. So I'm just going to take you a little bit on kind of the journey that we went through as a local authority that Jamie started to outline. So as a local authority, the whole systems approach really came at a good time for us. We were at a crossroads in terms of the next steps, in terms of our healthy weight agenda. We'd carried out health needs assessments, looked across the life course at need, and looked at the evidence base, but really lacked a bit of direction in terms of the next steps and the right approach for us. Public Health England, as Jamie mentioned, developed a suite of publications, a very much step-by-step approach in terms of implementing a whole system approach. And the thing that struck me was that it was, it was tried and tested and had been co-produced with other local authorities. So we know that that it did work. In terms of the approach, I'll try and relate some of it back to our links with primary care and our NHS partners as well. So we held a number of workshops over a year period with a number of partners and stakeholders. So these included our GPs and colleagues within primary care, or practice managers from our NHS system, paediatricians, maternity colleagues. We had dietitians, and then a whole host of other partners in terms of school meals, libraries, planning, transport, leisure, our pharmacy staff, green space staff, and people from economic development, and also early years and schools as part of this. So the approach in terms of a whole system approach was it was a new approach in terms of the healthy weight agenda. So it was very much about changing some of the mindset of our partners. We know it's kind of a complex area that we're responding to, and very much we wanted to do it through kind of a new dynamic way of working. There was lots of priorities, I think, within public health at the time that we started looking at the whole systems approach, but it really, I think, epitomised health and all policies approach that the council and wider partners like the NHS really wanted to draw upon kind of key priorities and look at a local approach and draw on our local assets that we had within our communities as well. We very much had to look at cultural change as well. We'd often use kind of traditional methods, I suppose, and it was about testing out these new approaches as well. And I think from the start, in terms of a whole system approach, we wanted to look with very much our NHS partners as well, but shared ownership, so enabling that our stakeholders could see their part in the system as well from the start. And very much our community and voluntary partners were a very much a key part of this process as well. I think as part of the systems journey as well, for Healthy Weight, it was very much about keeping people focused and with us on the journey. So public health led kind of the process, but there was very much a want from people to kind of rush to solutions and rush through the process as well. So we had to kind of hold people back. There was time needed as well that were coming from different cultures, so from our NHS, from our voluntary community sector, from local authority, from businesses, and to build that relationship, trust and respect from the different elements of work as well. And it was trying to, I think, as part of that process, create open and honest conversation within the system network, and that did take time as well, but acknowledging, as I mentioned, the different background and views and starting points that people were coming from as well. I think we did get to the point, and it took a number of months in terms of that shared vision and shared ownership, and where people could kind of see their place in the system all working as one. And it was really useful just to learn insights from each other in that kind of safe space of the whole system journey, and maybe to test out some of the innovative ideas that we had within that as well. So I think within the whole systems journey for the local authority and wider partners, there was very much a change in thinking around, I suppose, collective gain. And I think a lot of partners, including health colleagues and wider colleagues, had come from more individual benefits, but realised actually that it needed to be kind of collective gain if we were going to make any inroads in terms of health and well-being for our residents as well. Next slide, please, Jamie. So I'm just going to look at some of the enablers and challenges in terms of a local authority, what we experience with partners, and then just pull out a few enablers and challenges as part of this journey from a healthcare system point of view as well. So some of the enablers were very much senior buy-in. So we needed the senior buy-in of senior leaders, not just within the local authority, but our wider system as well. So from our NHS and from some of our businesses as well. We needed to really make sure that the senior buy-in created the environment for change and culture. There was very much a joint ownership as well, which I said, did take some time, so that everyone could see kind of their place in the system and how they could contribute to working to reduce obesity and improving the health and well-being for our residents as well, and acknowledging that public health might be leading on the approach, but very much that we can't do it alone, and it is very much a collective action as well. And just that it aligns not just with many local authority priorities, but wider priorities as well. I mentioned the health and all policies approach that we were taking, that addresses many of kind of the local resident priorities that had come up through consultation in terms of local economy and social care and health impacts. It very much supported a community-centred approach, so it was very much looking at the insights and experiences and looking at the assets that were in our communities, and very much building the strong lasting relationships with communities as well, which I'll come on to in a later slide, in terms of the whole system approach. And this process really helped us kind of go on to develop further long lasting relationships and pieces of work with some of our key communities. There was definitely challenges along the way, so very much a change in mindset, very much, as I mentioned, kind of consideration of the local context and consideration of the aspirations and challenges as well of different organisations. And I think just acknowledging the change of mindset in terms of the system approach work was quite heavy going in places, and it was making some of the concepts, assigned concepts, I suppose, more accessible to everyone that was involved as well. Very much allowing time to build in that relationship, and trust was key. We were in it sort of for the long haul, not a quick fix. And we really kind of needed that time to build those relationships and trust as part of that. We need very much sustained buy-in and commitment, so very much for the long haul, not a quick fix, and that many of the actions sit outside of public health, and we are reliant on a partnership approach and a collective approach from other organisations such as healthcare and our wider workforce to support with that as well. Just really the managed expectations, as I said, as we started the process, lots of colleagues from healthcare wanted kind of immediate results, and we tried to move the partnership beyond that, looking at individual actions and looking at sustained actions as well. The resource allocation, it was acknowledging that there needed to be protected time and resource to design and sustain approach if we were going to make a difference for the long-term health and well-being of residents as well. And in terms of our added enablers and challenges, in terms of this work, it very much took a sideline
Com licença, doutora Gibson. Por gentileza.
Excuse me, Dr. Gibson, can you conclude your presentation? You have only a few minutes.
Do you need me to try?
Yes, please.
Okay, she's just asking if you could conclude your presentation. I guess maybe they're out of time.
Yeah, no, that's great. Jim, just the last slide, please. So this is just really some work that we have built on that I mentioned through the relationships through our system approach. We have a Healthy Weight Alliance, which we were able to build on from the momentum that we've established with our partners, and very much it relied on our common goal and purpose that we established through our whole systems working, and allowed us really to have many more partners and to be more representative than we would have before we did the systems work, with very much a remit in terms of lobbying, sharing good practice, and bringing partners together for that shared ambition as well. We then have been able to build on this with our Healthy Weight Declaration, with health partners and with local authority partners, and really trying to build on a whole system approach to look at sort of strategic vision, and aspirations for the council in terms of working with our hospitals and NHS on vending machines in the food environment, and our HR and workforce development as well on health and wellbeing. And just to mention our supplementary planning guidance as well, it furthered our relationship in terms of the system approach with planning, and really using planning and health to look at restrictions on new hot food takeaways. And we were really able to use this approach to tackle health head on rather than just kind of the traditional policy approaches as well. And we were able to successfully control the proliferation of new hot food takeaways in areas of really high levels of deprivation for children as well. And since we've implemented this, we've had fewer applications and fewer approvals for any new hot food takeaways in these areas of deprivation. And just lastly, it allowed us, in terms of the approach, I think just to build on much of the work with our communities in our MEC, so making every contact count, so looking at our day-to-day interactions, using opportunities to have healthy promoting conversations about health and well-being and discuss health and well-being issues. And we've very much been able to work with our staff within our hospitals, with a MEC lead who's been able to implement some of the health and well-being areas and work into areas that we couldn't tackle previously as well. Thank you very much.
Thanks, Emma, and sorry for us going over, but there's some links.
Muito obrigada, doutora Gibson. Dr. Jamie Blackshot.
Thank you, Dr. James Blackshot. Sorry for interrupting because of the time, but later on, we're going to have an opportunity to talk more, and we'll have questions from the audience. And continuing the presentation of the UK, I ask Dr. Rosetta West. Doctor, you have 15 minutes.
Thank you. Can you hear me clearly?
Sim.
Thank you very much. My name is Rosetta Juliana West. I work and live in the United Kingdom. I work at the London South Bank University as a nurse educator. And thank you for having me. Many of my associates and commentators have covered some of what I would have said. However, just to put my presentation in context, just before I share my slides, I have, over the last 15 years, developed and led the diabetes module at the London South Bank University. From a generalist perspective, I'm not a diabetic nurse specialist. In the UK, we have specialists and we have generalists. I am very much a generalist. Okay, what we have observed locally, nationally, as well as globally, is the increasing number of diabetic individuals, particularly type 2. So what I'll do now is I'll share my presentation and we'll take it from there. Oops. And for some reason, it's not sharing.
Ok.
Bear with me.
A senhora já...
Okay, I see it now. No, it's okay.
Agora sim.
Do we have it?
Ainda tá tudo negro.
Oh, I can see it saying stop share. And I'm going to stop sharing and I'm going to start again. Bear with me.
Ok.
Yes, and I am going to share my screen.
Mas ainda não conseguimos ver a sua apresentação, Dra. West.
We still haven't been able to see your presentation, Dr. West.
I hear you. It's a new share. Let's try again.
Vinícius, você recebeu a apresentação da Dra. West?
It worked before, it's not working now. Bear with me. I may have to go out and come back again. Resume share, it says. Gustav, have you got my slides?
Yes, I have. Yes, I'm going to talk to Vinicius so he can get the presentation and share from there. Okay.
That's lovely. But I can see the clock ticking down. I come alone as opposed to a
Doutora Rosetta, a senhora consegue compartilhar conosco por e-mail e aí a gente tenta compartilhar a sua apresentação?
So I will keep going. Just
can you try and send again on a different email?
Okay. I'm going to try one more time with what I've got. Okay, bear with me. This should work.
Okay.
Let's try again. Technology. Here we go. Slide share. That. Let's try again. Aha!
Agora sim, estamos vendo sim, doutora West.
Now, yes, we can.
Yes, you can. Okay, marvelous.
All right. Then.
There we are.
Can you,
Even better.
Can you put, yes, thank you.
That's better. Presentation. Lovely. So basically, I lead on diabetes management from a generalist perspective, and it's looking at sustainable solutions. Okay? And as I said before, we have seen increasingly that our diabetic and other long-term conditions have increased, particularly over the last 15, 20 years. And we've had to turn our attention. Moreover, we've seen that the majority of our diabetic patients are not just children, not just young adults, but elderly, in particular type 2 diabetes. So therefore, we have looked to solutions, because the other part, my other specialist area is in sustainable development for sustainable education. And it, again, is from an educator's perspective as a nurse. We look, going back to diabetes, looking at diabetes, the pathophysiology, type 1, as I said, in particular, the type 2 diabetes, gestational, the pregnant mother who is already diabetic. We're looking at preventing as well as managing and detecting and screening for those micro, macro complications and seeking sustainable solutions. As I say, I'm a nurse and I'm looking at education. So I'm supporting nurses who come to do this particular module from a plethora of backgrounds, in particular, primary care nurses. And this is what we advocate. This is what we look at. We look at managing sustainable solutions in a diverse society. In the United Kingdom, we have individuals from all manners and all areas of backgrounds, life, races, ethnicities, etc. We look at those intersectionalities. We look at those cultures. And I bring in the word cultural competence as well as its intelligence that will drive what it is we are trying to achieve. In terms of nursing and midwifery, we address public health practices in the United Kingdom from 3 levels: the individual, the community, and the population. And when we have our discussion, we can talk a little bit more about that. Looking at the primary care sustainable solution underpinning of the diabetes module that I lead and continue to develop, we're asking those questions. Who, what, why, when, where, and how. We recognize that there is no easy answer to any of these, but we have got pointers that we need to work with. We know that when we look at, or at least this is what we advocate, this is how the module advocates and allows practitioners to look at their own set of circumstances in terms of managing diabetes from a biomedical model, using biomedical models in terms of cultural intelligence and competence, looking at the educational model and approach to health promotion, health education, health protection, looking at social change approaches, looking at self-empowerment approaches, looking at patient-centered, client-centered issues. I heard with intent and a lot of interest from our Canadian colleagues about the 5 A's, very, very apt and very appropriate in our society. So there are similarities. And we use various health belief models. In terms of being sustainable and looking at sustainable solutions, I emphasize the issue of context. Again, I emphasize that there is not one solution that will fit everybody's needs when you're managing diabetes. Look at the context, look at the area. We have inner city needs as opposed to rural needs. We have needs that relate to culture, religion, ethnicity. resources. We have a situation in the United Kingdom where we talk about postcode lottery. Dependent on where you live, it will relate to what you can get and how your needs are addressed. So we look at collaborative approaches that involve the individual, the family, the community. We look at clients' home, where they live, what they can access, what food is available in every setting, in care homes, in residential homes, as I said before, in the city, in the towns, in villages. I work in the city, I live in a village. So we encourage within that diabetes module the issue of listen, be attentive, be respectful, understand the context in which you are practicing and the remit of your role. One suit does not fit all. Yes, we have obesity, but does the individual recognize their obesity as an issue related to their health, related to their type 2 diabetes? We encourage, or I should say within the module, we encourage our participants, our students, our primary care health workers to look at the evidence. And we use, by and large, nice guidelines. But guidelines are guidelines. Again, every guideline will not take on and address the specifics of a particular situation. Apply those guidelines in context. That's the message to our participants through our diabetes management module from a generalist perspective. We also encourage our participants who are nurses to look at evidence, scrutinize the evidence. Yes, apply evidence, but scrutinize it. Does it apply to your specific context where you work? Collaborate with others. How does that evidence fit the resources that you've got? And how can you deliver the service? Scrutinize the literature to ensure its appropriateness and the context. In the United Kingdom, we talk about individualized diet advice. Again, one eating pattern does not suit everyone when it comes to weight loss. So what can we do in primary care teams? We talk about training, and I offer you one tool that is used in terms of training, Scope e-learning. And we've used a lot of e-learning during the pandemic that has been applicable. What I'm delivering to you has been pre-pandemic, during pandemic, and I suspect very much post-pandemic. We've had this pandemic, we don't know what's coming next, but we need to be ready and appropriate and applicable. We like to ask the question again, how do you feel about this? Is what we advocate. So it was interesting to listen to my Canadian colleagues. Ask, how do you feel about your weight? Again, I put it out there that the issue of weight is not interpreted culturally in quite the same way across the globe. Where it is interpreted, we encourage our patients to have weighing scales, should and if they address the issue of weight being appropriate and connecting to their morbidities. We refer and use the issue of referral in terms of the obesity pathway. We collaborate. This is, again, advocated within the diabetes management, the issue of collaboration with other agencies, appropriate agencies. And we talk about healthcare professionals, but again, we need to accept and recognize the importance of those other culturally accepted agencies that can get under the skin and into the minds and into the behavior of our patients stroke clients. And some of those other individuals may well be faith leaders, respected members of the community, trusted members of the community. Also, we discuss and approach the issue of social prescribing. In the United Kingdom, we have a system whereby practitioners can prescribe activities that would otherwise cost in terms of money. Attending a gym, having a fitness individual to do one-to-one, that may cost money. And not all participants can afford that. Not all participants will want it either. So we address that also. So in the UK, we start by understanding what people are eating and their personal goals, their understanding of their weight, their food choices. We address it from a cultural competence, intelligent perspective. We try to understand, and we aim to understand what the person knows about nutrition. So that is where we can meet them from the outset. And we can pitch the discussion thereof at the right level, using the right language. And when I say language, I'm not referring to English, French, Spanish, Hindu, and so forth. I'm talking about the words and meanings that are meaningful to the individual. And sometimes as professionals, we can pitch the conversation away from. We need to meet the person, the individual, at the point that they understand what we're talking about. For sustainable changes to eating habits, we accept that persons have to like what it is they're eating. They have to recognize what they're eating. And again, cultural competence comes into that. Persons also need to be able to prepare as well as cook, as well as purchase what it is. Can they afford it? Can they get it? Can they access it? And if they can't, what is it that we can do to facilitate? We talk about food banks in the United Kingdom. Yes, in the United Kingdom, we have food banks. Okay, where individuals who cannot afford to buy the food they need can go to get it at a cheaper, more reasonable price. We know that the amino acids in protein have been shown to be insulogenic. So we talk about and refer and collaborate with nutritionists with regards to the inclusion of protein in diet. Much of the evidence based on low and very low carbohydrate diets, we have found, and we discuss within our diabetes management course, that there is huge variation in definitions and in what is actually eaten by our patients and others. And of course, weight loss is not a uniform thing. Individuals lose weight at individual rates in order and address their particular morbidity in an individual way, and we take that on board. So the diabetes management that I developed, the module that I developed, and it's evolving as we speak, will change as society changes and our needs change. To tackle obesity in the United Kingdom, we have a tier system where the first two tiers deal with primary care and community advice to identify and reinforce healthy eating and physical activity messages, having done the appropriate assessment. And then we move to tier 2, where primary care within the community uses interventions, including possibly referring for commercial weight loss programs and social prescribing. And then we look at tier 3 and tier 4, where we have a more medicalized version of intervention. Up to tier 4, where bariatric surgery is considered. So in summary, the diabetes management, a generalist perspective, looks at sustainable solutions, and they are varied, dependent on the place and the context in which we are looking at food diet, and in particular, type 2 diabetes or diabetes as a whole, in terms of prevention, in terms of its management. High up on the list is that culturally intelligent, competent practice. We can't ignore it. Ignore it at your peril. We address public health practice and engagement from 3 levels: the individual, the community, the population. We look at primary healthcare solutions that addresses the individual, as I say, the individual, the community, the population. We look at collaborative approaches, collaborative to include, yes, the multi-professional team, but also the multidisciplinary team. And that may well include faith leaders, religion, church leaders, all within context. We look at evidence-based guidelines, and we encourage within the module that persons, professionals, nurses scrutinize those guidelines in order to make them appropriate for practice. And then there's training. There's training that we can contextualize and use. And essentially, when it comes down to it, in addition to evidence, it's what works. It's what works and in context. And we use a number of resources, which I share with you with the slides. And thank you. I look forward to the discussion and the debate. And I think I'm within time, I'm not sure.
Okay, Dr. West.
Okay, Dr. West.
I aimed at 10
Thank
minutes.
you very much.
Okay, thank you.
Yeah, you went over just a bit, but it's fine.
Thank you.
Thank you very much for your presentation.
Thank you.
And the first presentation that we had of Jamie and Emma, it was surprising for us that not only Brazil that has continental dimensions in which the SUS, the health system, has challenges in dealing with the differences and diversity of communities. And it's very important as well what you mentioned in your presentation about the care with diabetes. So I'd like to make an announcement considering there was a problem in the Trinidad Tobago. There was a power outage, and unfortunately, they couldn't stay connected. So for this reason, we're going to bring forward the presentations, the Brazilian presentations, okay? Now I'd like to invite
Miss Fernanda Noneto. The national experience will also consist in 2 moments. Fernanda Noneto is a nutritionist from the municipality of Palmas, Tocantins, since 2015, specialist in public health with emphasis in collective health and family health, specialist in preceptory in SUS by Sírio-Libanês Hospital, and acts as preceptor from the multi-professional residency in family health and community in Palmas, and she will talk about the importance of the mapping of the territory for the planning of actions in health. Next, we are going to have the presentation from the municipality of Curitiba, Paraná, which will be performed by Miss Patrícia Aldri, specialist in collective health, in management and public health, and nutrition, clinical nutrition. Master in Collective Health by the Federal University of Paraná, and currently coordinates the support to the APS in the Municipal Secretariat of Curitiba, and she will present the organization of care in nutrition and food for people with excess weight and the organization of nutritional therapy in the network from the municipality of Curitiba. So to initiate, I will invite Ms. Fernanda Noleta. Welcome. You will have now 15 minutes for your presentation. I'm going to tell when there are 5 minutes to end. I thank again for the invitation. It is a pleasure to receive this invitation from Segan to talk a little bit about the experience here in Palmas, Tocantins, about this mapping of the territory. So, in the next slide, please. Can you pass it to me? Okay, it's here. Thank you very much. So I'm going to talk about where I'm speaking from. I'm from Tocantins, which is the most recent state in Brazil, and we have a population that's almost in the next census of 1.5 million of citizens. It has 8 regions, so as you can see from these differences of colors, these regions of health and the capital, which is the municipality of Palmas, is in the most central region, so the central region of the state. The state has a diversity, a great quantity of municipalities, but almost 85% of these municipalities have a population that is very small. So the greatest part is in the capital or 3 or 4 municipalities. You can go to the next slide. I cannot see. So in Palmas, a little bit of Palmas. In Palmas, we have a population of approximately 303,000 inhabitants. We also have 8 territories of health. We also have a coverage of 85 teams of family health, which are distributed in 34 basic units for health, so we can have a coverage of 100% for family care. So to cover these 34 basic health units and give support to these 85 teams, health teams, family health teams, we have 13 multi-professional teams, which are composed by 11 nutritionists. So we have 2 territories which do not have professionals. And from these 11 nutritionists, 8 are resident, being 4 from the first year and 4 from the second year. And with 2 nutritionists, which are from the contract connection. So the municipality of Palmas, our network for primary care, has a difference because it connects with vigilance. So we have a network for attention and care and vigilance in health to be able to approximate the attentions of vigilance and care in health. And here in these colors to identify the territory, in this case, the territory where I stay is in this most central region, this green one here in the territory. You can go to the next slide. Okay, I brought some pictures, the municipality here to show a little bit the face of Palmas, which is a city that has a lot of green parts that due to these, we have an artificial lake, there's a lot of water, waterfalls, green areas, and some institutions here from this mapping that was done. Next slide. So within this mapping, how did we begin? This mapping is already a characteristic from the multi-professional team, which began in 2014. In 2014, we began to have a NASP team in the municipality of Palmas. This thanks to the beginning of the multi-professional residency. So there was the implementation of professionals which allowed to begin the NASP team. So we began with 3 teams, and then we managed to increase the quantity of professionals. And since then, we are performing what is called the situational diagnosis, which is to know the reality of the territory. Is a little bit of what Mayara said in the beginning. Kelly also said about it, that for you to know about this territory of health, which is there where we're working on. So what we used initially for tools, it was the notebooks for basic care attention, which talks about the issue of NAS from the work that we do here. And each time that we change a cycle of residency, there where they say 2 years, we do an update of this diagnosis. And if there is some kind of change in the organization, in the work procedures, again, it is important to do this update of the diagnosis. And now in 2021, I began a course in a specialization in care for people with obesity and overweight. And one of the activities which was suggested was a social diagnosis of this territory. So we did an amplification of this diagnosis. We put those institutions, those equipments, public equipments that develop actions for food and nutrition security. We focused in the prevention of overweight and obesity. Next slide. Here in this image, you can see the map that we created with this tool, which is a tool that creates map for public equipments to promote health. And here the registry of some of these equipments, which would be fairs. In my territory's case, there is no plantations. We will be another equipment for so popular restaurants, so giving a food in a more accessible price for this population, which is more vulnerable, equipment directed for the promotion of physical activity and leisure, so other spaces to promote the issue of physical activity. Next slide. Beyond that, which are the professionals involved within this activity? The professionals which conduct this process of the mapping, this diagnosis, is the multi-professional team. This team is formed by nutritionists. In my case of my territory, me, I am the preceptor, and we have psychologists, physical therapists, pharmaceutics, and professionals, healthcare professionals, and physical education professionals, which are residents there. And within this territory where I act, there is also a phono doctor and audio doctor, and this team of professionals conducts this diagnosis with the support from the for people who integrate family health care and who are part of this territory. So in my territory, we give support to 3 basic healthcare units in which we have 8 teams for family health and a team for these consultations in the street. So all these people help to build this diagnosis. But it's very important for us to talk with other people, to go beyond health. So to talk about with professionals from the Secretariat of Health, the population that goes to this unit, the representatives from the local council of health, municipal councils, people from the institutes, public and private institutions, schools, and other institutions, beyond other institutions that most of the time are not within my geographical area, in my territory, but they are referenced to meet the population of this area, which is the case of CRAs, which are the centers of reference and social assistance, the tutor council, social council, and then other institutions. So we are able to try to recognize which are the tools and institutions and the equipment that this population can refer to try to help in this promotion of health, which is more amplified. Next slide. So I brought here some registries from the meetings that we have. These are from 2018 until 2020, that due to the pandemic, we were not able to have these moments. So team meetings with the local council, also between professionals, health professionals, with other secretariats. For example, this one is for the social action due to the birth of the person. So within the secretariat, the meeting between secretariats, with nutritionists, physical education professionals, and the meeting between the members within the territory. So within our territory, what is the characteristics of this territory, to think about actions considering the characteristics of this territory. So then what did I find here to characterize this last map in this diagnosis is that within this region here that I'm part of, it is a region that is central, where there are many public institutions, private ones, commerce, restaurants. So there is an environment that will be to obese people, but we have parks and areas that make it favorable to develop physical activities without necessarily having a person that have a cost to develop this activity. So like I'm going to talk about later some alternatives that we also developed, and which would be, for example, the risks and potentialities identified in these territories. So we find, like I said, this obesity environment where you can have vulnerability, drug trafficking, irregular population. It's like a population in a risk situation, old people that need special attention, which have some kind of violent situation and vulnerability, a great number in the population with food disorders, which can participate in the actions of CAPIs, which would be the Center for Psychosocial Attention, and other vulnerabilities like the issue of urbanization, people who are not dependent on SUS but have this resistance to let health get in their houses and to recognize this reality. In some units that also in this local council of health, it's not very strengthened. So the participation, the popular participation is more fragile. Next slide. And now you're going to have a few registry from activities which were performed with old people in institutions of long permanence of capacity training with the population in the healthcare unit with groups for education and health also. Okay, and then beyond this diagnosis and this mapping, what do we have here? The epidemiological diagnosis and food one and nutritional one. This was a proposal within this course, training course, and it showed that within this territory where I act, we have had a population of only 3.5% to 5.8% of the population, total population, considering the life cycle, was evaluated by CISVAN through going to this population, to this population going to the basic care unit. So we were able to know that in all basic care units, we have ISUS, which is part of CISAB, and we have a system that collects this information of wave, and we can see this profile. However, it's not very amplified considering this entire population, possibly due to my region having a population that is not dependent on SUS. Maybe they did not look for this health unit. So considering this population that was evaluated, we found a percentage between 5.7% until 62% of old people with overweight or obesity. So about the issue of comorbidities, we found beyond the taxes, the rates of obesity and overweight, we also find hypertension and diabetes. So as to the food consumption, within our territory, the promotion and the raising of the situation and consumption is done with more numbers of people answering with collective activities, or even in activities that we call in the program for health in school, which are developed within the municipal centers of children education, and then which will be in kindergarten. So we noticed that within this questionnaire or food consumption, the increase in the consumption of food in front of a screen, ultra-processed foods, and the reduction of consumption of food and legumes and greens, as it was shown before. And now I brought some new important things to say. So what did we happen with this mapping and this diagnosis? So the first part was the issue to discuss these concerns that we had and identify what were the causes, the consequences, alongside the team from healthcare, and focusing in the governability of the participants. So who is in this meeting? Who is there? What can you do to change the situation, to not put a blame in external cause that may be in a situation that you cannot change, and then add later to put the right about the objectives, actions, and activities which are necessary for you to reach that objective. In this last plan, the provision for the beginning of these activities went for the year of 2022, considering this change in the residents team. So some of them are leaving now in the beginning of February, then there will be a new team in March. So we are going to begin with this new team. So some registries, photographical registries, shows some actions that we did from the diagnosis which were identified previously. So we noticed the necessity, for example, to work in actions for food, mainly in relation to the consumption of fruits, legumes, especially for young children, and in order to notice the importance of what they think when they offer the food, and also activities of education, food education in kindergartens, meeting with old people, talking about food consumption, talking about the reduction of ultra-processed foods, sugar, and fried things. Here we also had meetings with the population of a general group, people that frequent the basic care unit, which we have a index of overweight, workshops, culinary workshops, so putting the population to put their hands there and work and think that it can be very healthy and easy to do some practices. Here, there are also groups to promote health. So one of the things that we identified, and most of the times people say, I want to do this activity, there is a space, but how am I going to do it? So since in our team we have physical education professionals and physical therapists, so then we did a talk to them, we created groups of work practices. We created groups where we can work together, so with integrative practices and complementary practices to perform the talks and therapies. So we also identified the necessity to begin a group to combat the issue of smoking, to perform activities in the night time with parks, with people that would frequent parks, and groups directed to those people who are already with some problems due to the issue of overweight and obesity, with orientation about how the posture, stretching, and the results. How do we present them? With these results, we show through reports which are monthly, at each 4 months, be it by the municipal secretariat or for the municipal council of health, or for the program for residency, which is an integrative program for health. So these are reports done continuously. However, we notice that there is still the necessity to strengthen these tools for us to be able to monitor and evaluate more efficiently and more visibly of these actions alongside this municipal policy of health. And to finish my speech, I would like to thank for the invitation to be able to be here, participate in this event, which I'm amazed by all the speeches, and my contact address for those who want to share some experiences. I'm here available. So thank you very much.
Fernanda, nós que agradecemos.
Fernanda, we are the ones who thank for your participation, showing the unified health system in practice. We are very happy to see an experience that demonstrates the importance of mapping the territory and how it can be potent for the organization of the organizations, the primary healthcare teams, with other equipment from the territory and other sectors. Thank you very much. Now I invite Ms. Patricia Alves. Welcome, Patricia. Thank you very much. Can you hear me well? Yes, we can. Okay, now I'm going to try to share my presentation. Let me see if I can do it.
Nós já conseguimos ver sua apresentação.
We can already see your presentation. Can you put it in the presentation mode, please? Okay, I'm trying to figure out where do I put it. Can you see it in the presentation mode? No. No, we're not. Okay, now you're seeing. Okay, fine. Okay, Patricia, I'm showing here, okay? Now I have a challenge to talk in 15 minutes about our work here in the primary healthcare. I talk from Curitiba. I'm a nutritionist. and talk about from the Secretariat of Health and from the Department of Primary Health Care. Can you pass the slide, please? So our care network, it is composed by 108 basic care units, be around 50% in the strategical model of family health and 50 other in the traditional model. This is a complete network with 9 units for ambulatory, 13 central support centers, 5 specialized units, 2 centers for odontological specialties, 2 municipal hospitals, 1 municipal laboratory, 1 regulator complex, 1 central, 1 vaccine center, 1 zoonosis center, and 1 unit of psychiatric stabilization. Now talking about primary attention and nutritional one, we have 25 nutritionists or dietitians. We had 30, but one of them were left us, so we approved and this public tender for us to have more professionals. So just thank us. So I tried to bring here the guidelines from CONAN, and then I'm going to talk a little bit here because the focus is the program for attention for special attention and the care for weight and obesity. But I try to bring here a general overview on how we organize PINA in our municipality. So I'm going to begin from end to beginning. So the 9, which is cooperation and articulation for food and nutrition security. So here, this is a theme about food security, is a transversal theme. It goes through all the programs, strategies, and go from the formation of workers. And we aim for that. We like to do that in the ingredients that we do with nutritionists, where we consider nutritionists as if they were the people that will disclose nutrition in their territory, in their units. So we, within this formation, their education, we talk about the issue of food security so that they can also pass this content for the unit, the territory. But we also have a secretariat, municipal secretariat and food and nutritional security here in Curitiba. And I'm also part of a CONSEA, which is Municipal Council of Food and Nutritional Safety. So health is also there in me, represented there. So the 8th point, which is about control and regulation of food, we have departments of sanitary vigilance that takes care of that. The 7th one is about research, innovation, and knowledge in food and nutrition. The Municipal Secretariat of Curitiba supports researchers about the theme of food and nutrition. We have a ethics committee and research in the Secretariat of Health, which we including have researchers with partnership with Federal University of Paraná, especially in the theme of food, nutrition, the program of nutritional food for people with special necessities of feeding. We have other researches done here in universities, and then we have the program residency program, and we support and disclose the researchers in the municipality. The 6th part, qualification of the workforce. So we have the habit and the permanent education, be it from nutritionists and the primary care team. Recently, we had the information that we are in returning this care in a normal way. Let's say after the pandemic, we are here trying to take care of the chronic and more severe patients, and we did many classifications for the nutritionists so that they can take care, and also the other professionals from the team from APS, that they have a Center for Education and Health, says Curitiba, which helps us in relation to the presentations, the studies, the training, and talking about the 5th guideline, participation and social control. We have the additions that participate in many councils from the mayor and also the Secretariat of Health, and as I said, I participate in CONSEA.
Gestão das ações de alimentação e nutrição.
Management of actions for food and nutrition. We have a coordination in a central level, which is me. I am part of the coordination of support to primary care, which are inserted there. Since I am a dietitian, I also do a coordination for food and nutrition. And here we'd like to highlight the intersectoriality, which is one of the items that we work on, and to put requirement that we need to take care of, which is intersectoriality. So the fifth guideline, which is vigilance and food and nutrition vigilance, we have these people that evaluate the nutritional state of users from the basic care unit since 91, and from 2001 it was inserted within our electronic charts. So it made it possible to have our own system of electronic charts, and this made it easier to analyze the data. And now we are very happy to say that we returned the bulletin from CISBAM from last year, which was a practice that was asleep, let's say, in the municipalities. So we have all this evaluation, historic evaluation in the nutritional state from the population, user from the basic care units. And then since the evaluation of this historic, so it's very nice, it's in our page.
We have these two things as with the Educational Secretary of Secretariat of Education that assesses the performance of the students, and then we had the marker of food consumption. There was a demand that we needed to include now, and it would help us to assess better these issues. And besides basic equipment that we have in the units and health units. And then in item 2, last item, which is the adequate adequate diet, and then we have to go through the educational materials that we created, capacity training or capacity building, and we had the portal that I'm going to show later here, the strategy Alimenta Brasil, and we're trying to strengthen it. Over 3,000 professionals were studied, and the nutritionists of the network are all tutors from this strategy Brazil. And we trained over 3,000 professionals in this strategy. Besides the care and about obesity, the program in nutritional education that I'm going to mention, besides the other needs of the territory. You can go to the next slide. I wanted to mention here a little bit of the focus of the nutrition, and these are the demands in primary healthcare. These are the demands that we have in the municipality of Curitiba, which are the largest demand. Of course, nutritionists, they care for other situations and other demands that are present, but that's what we realized that it was necessary to invest in. So the care for people with special needs of food, and the care for pregnants that have diabetes, hypertension, and obesity as well, with body index mass over 35, and that's the third cause of health problems. It was obesity. So we had a very good work with the unit and all the professionals of primary health care, and we added the nutritionists in this assessment as well. And the care of children that have obesity too, we can have the analysis of this data and to check who is in the program Auxílio Brasil, and to check the nutritional status, and to tell them which are those students, and to have more individualized care and service and treatment. And we're going to start this year. the project of treatment we're going to start this year. And after the pandemic, the treatment for high-risk users of diabetes that have hemoglobin higher and at very high levels. So we had care of hemoglobin that in this age group when it's going to be open, and also the users of obesity both in the individual as well as the collective situation. And we're going to focus on these two items, okay? And also the special health or special needs program, Bunker, that is the program that is the apple of the eye of the Secretariat, PAN, that's when we had the professionals that became part of this health, this network, and it helps kids with 2 years old with allergy or food intolerance. And we have a pediatrician and an allergy specialist that deal with specific cases. So we have two professionals to deal with these cases that help us all a lot in our city. The other part of this program is for patients with malnutrition that is secondary, or diseases that have problems in the gastric system using IV, and this is in the scope of APS, of primary health care. Even though there is specialized treatment and all the organization and it works well, we care especially for it in the primary health care. They are nutritionists that provide the service to these users. The resources are from the municipality. There is a protocol on our page that is also possible. It's not very up to date, but that's the same logic, and we developed the handbook of the patient and nutritional therapy that is very thorough, and it's also available in our page. In order for us to organize SPAM and the Secretariat, is starting with the hiring of nutritionists, because we also provide nutrition guidelines, and in order to do this, we needed nutritionists and dietitians. These nutritionists back then, at first, I started working and providing treatment as well, and we had many courses and in which we saw the theory and the practice. We tested the diets, we tested the recipes, we developed recipes along with the University of Paraná. There were some specialists that were hired that provided us treatments as well, trainings, and we developed a protocol with a flow that is defined. And after that, there was a closer treatment, a closer alignment with the nutritionist to have the same alignment. And because we're all part of SUS and we have to provide the same service, the user cannot be confused or concerning this. And we had the support of CRN8 because at first there was a difficulty in the specialized care and the three levels of care that are necessary. So we got close to these three levels of care, and there was some training concerning the guidelines of PAN and for the follow-up, and we had the support of CRN8 to develop these meetings with specialized care. These are some pictures of some trainings and some classes that took place. And in the practice, in the test of diets and supplements for the recipes that we were testing, also at the lab, and also in the acquisition of the equipment that measure fat in the body. Here I wanted to show you some treatments that were provided with multiple professionals and also practice. We're going to practice what we taught him. Now I'll talk about the line of care of overweight and obesity. So we organize the actions of prevention and treatment of overweight and obesity in the municipality. There was a work group to create this line of care of professionals of the Department of the Primary Health Care, Specialized Care, nutritionists, and professionals of physical education that work with primary health care. And there were agreements in terms of the three levels of care according to the regulation. And in primary health care, there was an agreement and all raising of awareness of the under the coordination of nutritionists and professionals of physical education. And the APS was the lead part of this care. We also had some trainings concerning the topic in partnerships with the Federal University. We had meetings with the labs in which we could see the face of the nutritionist that provides the service, that sees this user, and to ask him, what is your difficulty? And asked, what do you need in terms of information from me, for a professional in primary health care that I can provide for you? And what do I need that you can provide for me to know what this user is doing at the specialized care? So this training was very enriching. And then you can see the pictures here for users, and we can also have offer both in collective offers as well as individual offers of service. And some users need find collective work okay, collective service okay, but some others need individual service or individual treatments or medical appointments. And I just wanted to mention the cares and the line of care of overweight and obesity. That's just to mention some points here. And let's talk about the practice in terms of the line of care of overweight and obesity. We use technologies to promote reflections on change of behavior, such as motivational interview, the trans-theoretical model to assess the awareness and the willingness to be participating in the activities and the level of interest as well, the supported self-care as well. And now we're updating, and we actually have a material that is published in this area of support, and we're finalizing a new edition that will be released this year, probably. And the nutritionists, they have an individual and collective service, provide the service, and something important that has been mentioned is that he's a regulator, he or she is a regulator of the specialized care. It's important because the nutritionist, the one that sent the patient to this specialized care, was the doctor, and now the only people who could do this are the nutritionists because they understand the line of care. They assess whether there was primary health care service for the user and whether it was successful or not, and after that he can send it to the specialized care and maybe to bariatric surgery. The professionals of physical education have provided physical, individual, and collective service and monitor the data. And we have partnerships with the course of nutrition to provide services to children and teenagers of users that have obesity. And I mentioned here that we needed to advance in the technologies of communication. And a very important example of this was during the pandemic. We have some health clinics or health units that have health cell phones that are available to be used by the professionals. And I was very pleasantly surprised to know that the patient had a follow-up with in the primary healthcare and sending messages to him to see how are you, and the testimonial of this patient knowing that he's being cared for. It was very good, very positive. So I think that one of the things that we need to advance in is the use of technology to because the volume of people with overweight and obesity is very large, and we need to advance in this area because the people who can get the service and treatment remotely, we have to invest in this. Otherwise, we won't have enough people to do this, considering the number of people. And actions of self-care for the patients that for patients that have a very stable cognitive part, it's very important to help him in the dealing with overweight and obesity. These are some, excuse me.
Por gentileza, pode concluir.
I'm
Obrigada.
finalizing, okay, sorry. Just these some of the pictures and the intersectionality, considering you can go to the next one. And I just wanted to illustrate the portal, which is Listen to Your Heart.
Avalia como que está a alimentação, atividade física, o peso saudável, pode começar.
And we can see here the activities and the other things that are available. And we have a button here that is click here that when after the assessment that is performed, you can click there and they can show which kind of food is available in the surroundings of your city or neighborhood, or you can see which places that you can buy food you can buy at a more accessible price or a more reasonable price. And we're creating the app here, which is called Saúde Já, Health Now, that will guide the municipality in fighting obesity. And this data will go to the electronic control, and for users who go to the health clinic or health unit, will be able to follow his information. Next one. Thank you very much. Sorry for going over the limit. And that is my contact information. I'm available for you, to you.
Obrigada, senhora Patrícia.
Thank you, Ms. Patricia. Thank you for your excellent work that shows the capacity of the municipality of Curitiba in using their services, articulate the services aligned with the national policy of nutrition. I'd like to make some other announcements before we continue to Mr. Michael. We'd like to inform that unfortunately, the power outage is not over in Trinidad and Tobago, and we're trying to include it in the schedule of tomorrow.
Até o momento das perguntas, né?
And unfortunately, it was not possible for Dr. James to answer some questions, to wait until the end, but you can send him questions through email. If you have any questions on this experience, you can send them on his email, to his email. And now I'd like to ask Mr. Michael Gianna. Sorry, Mr. Antonio Leopoldo, representative of the Department of Family Health from the Ministry of Healthcare, to talk about the presentation. And then after that, we're going to talk about the comments that were made in the chat. Thank you, Mr. Antonio. You'll have 15 minutes to make these comments, and I'll let you know if 5 minutes before the end of your time. Apparently, his mic is not on.
Nós não estamos te ouvindo. Agora sim, agora podemos ouvir.
Não, ele está sem áudio.
Você continua sem áudio, Leopoldo.
He's not connected to the audio. Okay.
Agora te ouvimos.
We hear you now, not really. There's probably a connection in a plug problem.
Me presta fone aí, cara. Alô? Agora deu, né?
So now you can hear me, right? Yes. Okay then. At first, I'm gonna try and stay within the allotted time.
Ah, Leopoldo cortou novamente.
Your voice is not coming out.
No momento, não estamos conseguindo te ouvir, Leopoldo.
Unfortunately, we cannot hear you well, Leopoldo.
Ela fale agora sim, né? Espero
Agora sim.
Now you can hear me, right? Yes. Okay then. So first, I'd like to thank you. I'm Dr. Leopoldo. I'm a nutritionist, a civil servant. I've been working with, for the past few years, with policies of nutrition, public policies of nutrition, and I'm representing the Department of Family Health from the Secretary of Primary Health Care of the Ministry of Health, and our director and our direct the director could not participate, but it's a pleasure to be here because I'm a nutritionist and I've been working with this topic for some time. And I'm here at the coordination of primary health care, trying to help municipalities and states so they can implement these strategies in terms of care and primary health care in this country that is so gigantic. And that is I have this great satisfaction to be here, and especially to know the experiences of other countries and to be able to see how much Brazil has been working in the policy of nutrition and food policies. And I just wanted to highlight that starting in the sanitary reforms, or actually when our constitution was formed, the healthcare professionals were always committed to nutrition and food programs. SUS, when it was created, the law itself highlights the character of the aspect of nutrition for Brazilian population, and the policy of nutrition, I believe, in 1999. It was one of the first policies that was a very strong policy within SUS. It precedes the policy of
It precedes and inspires also the guidelines and the objectives of the policy. Also inspired the creation of the Secretary of Primary Attention. So the policy, beyond creating new materials to try to reach the importance of health, nutrition and real nutrition, and the strategies for nutritional and food vigilance, our different publics. We have a great cultural diversity in Brazil, be it from traditional people, our great urban metropolis, so people still living in situations with subsistence, but let's say a contact with the nature, be it a sustainability issue, depending about their natural resources, even people in great metropolis with habits that are sometimes ethereal, let's say, they would some high processed foods. So we have a policy, we want to try a policy that tries to reach these different publics. So I think that this policy of food and nutrition is one of the the oldest policies from the ministry. Always had this care with the guides and also the issue of regional food. And we are trying to dialogue with the territorial aspects and cultural ones from our population. And also in the articulation of the other sectors, the importance from the education sector, feeding in school as a first contact in the procedure of food education for children. It's also important for the knowledge and also social assistance, the caring the population with difficulty to access food, agriculture, We had here a period, a very strong period to work with food security, sovereignty, strengthen the familial agriculture, strengthen the changes in the first circuits of commercialization in a local level, trying to strengthen to give healthy foods, rich foods, nutritionally healthy foods, and also guaranteeing the strengthening of the local economy where there are the producers, the environment with the issues of waste, of production. Unfortunately, we have these characteristics. Let's say for health professionals, especially the nutritionals, when we're very militant in about healthy nutrition nowadays, when we see some experiences, talk about Canada's experience, when we talk about the guidelines, the attributes from primary attention are connected to these issues. So, for example, we have the first contact, the important to create a connection with the person, and from then on, know its necessities and be responsible for the health teams that we have a lot of teams now. We have 5,000 municipalities, more than 48,000 basic units. This is a lot of structure to care for people, many actions to promote health and care focused in the issue, territorial issue, in the care, communitary care. So trying to understand the culture, the environment, the food environment, be it referring to the health conditions of the individual, the offers, the available offers, the characteristics of the local economy, the products used in feeding, the family relationships in this procedure, where we are looking to promote a care to health, thinking about, like Dr. West also put, in the attention to these levels of care of the individual, communitary, populational. So the first contact is very direct to the issue of the connection, to make the team responsible for giving this care, knowing the necessities of the individual, and even building the alternatives for their treatment, and knowing their difficulties being in the access, and also the actions of food studies, also the integrality, which is another attribute that we are trying to work on with all the complexity, like we said before. People from Canada, United Kingdom, they talked about the obesity issue, a complex study that demands a multi-professional work, which is the characteristic of the multidisciplinary teams, health multidisciplinary teams from health. They are multidisciplinary, they work with many professionals, precisely looking to have this approach to understand the metabolic aspects, the physical aspects, the psychological ones, and trying to, from this connection with the user, to try to build the therapeutic alternatives involving the different professional areas and the different levels of attention to health. And then the issue of how far it is. So the team responsible for the territory, that population which is there in their care, to identify their necessities, look for alternatives, and build their therapeutic itineraries, to have a follow-up and the sustainability, the maintenance of this treatment, to do the follow-up of this individual throughout its life, and the difficulties that they will naturally face and that can compromise somehow that treatment, that care, to always have a team that offers trust so that this individual can always have the services from the team and the unified health system. And from then on, to coordinate this work with the network, from this connection, this trust, this point of view, to build therapeutic alternatives that are more adequate to the profile of this user and this community. And from then on, we see experiences like this one from Tocantins, Paraná, in which this unit of health unit is an articulation space and connection with different equipments and public policies also. So this unit, they promote physical activities, they promote food and nutritional education, they have fairs, looking to make a connection with the living, exchange experiences, and mainly knowledge about food, nutrition, and the different disturbs related to these issues. So the public health system and primary attention works not only in the perspective of obesity, but in control of these diseases in order to promote health and physical activity. They cares like diabetes, the issues from basic necessities of food, which is also something that we look to strengthen the policies refer to that so that we can offer therapeutic options and treatments for these issues too of the diseases. Well, I think that the policy for food and nutrition here in Brazil, we have a privilege to work this in the primary aspect. We have 50,000 teams. So these teams are here in the Secretariat of Primary Attention. We have many departments. We have DEPROS promoting this seminar. And then the team from food and nutrition that maybe is one of the units that is the oldest one here in the ministry, like I said before, that has this responsibility to promote strategies to promote health, create this articulation with the different sectors, develop materials to orient, not only for communication alongside the user so that they can have access to information, but to make healthier choices, but also to qualify the different professionals in our team, is not only the nutritional professionals, but the doctors, nurses, so they can have accessibility and care with obese people, people who have special needs, they look to make a connection and have materials that are available in courses to be able to qualify themselves. And the strategies to articulate, which are amazing and important in relation to the other policies, which impact directly on what is offered and the cost of what is offered and the quality and processing of this food. How do they arrive at our table and end up, well, favoring and inducing some choices which cannot be, let's say, healthy or adequate for a health style in order to promote health. So we have DAPIS, which is a department that has a care with life cycle. It has been concerned with develop strategies, talking about not only about food relations, but also the development of children, food nutrition, and some communities, and also which are more remote or are in these favelas, let's say, we have a difficulty to reach there, malnutrition. And this department ends up taking the basic care, special care to children, pregnant women, so that we can have, let's say, an integral care in the individual, but also for the entire family, considering the different public's priority groups. The children in the Department of Family's Health is responsible from what we say, the diagnosis of nutritional and family vigilance, and of health in the Brazilian population, being an epidemiological profile. We're trying to distribute these teams in such a way that they'll be able to be closer to the territory, and then they can have a dialogue and live with people, creating connections, creating a responsibilization, to understand within the family which type of situation, complex situations, problems can be interfering in the family habits of the population. And then the Secretary of Primary Attention is already, I believe, inspired by all these guidelines and strategies to promote health. Now it is a It is consolidated for a few time in the Ministry of Health, but which has already been looking to be a protagonist in this importance to have a care, next care, to working with the promotion and prevention of health. And like I said in the beginning of my speech, nowadays, nutrition and food is part of the social rights in our Constitution, 6th article. It is a achievement from the professionals in these years, 2010. This right is a constitutional one, and the Secretariat for Primary Attention is here to preserve and to promote this right alongside the population through the strategies for family health, who aims to have this proximity and care alongside communities, individuals trying to notice their necessities and where they inhabit, and the offers that they have so that they can have better choices and have the assistance of public health available so that they can receive the proper care. I think this is it. Respecting my time, I thank for the presentation and the contribution of you all, and to reinforce here the role of the Secretariat of Primary Attention and Family Health, and then supporting and strengthening the strategies for food and nutrition so that we consolidate and incorporate the strategies within the team, so that they can be part of the day-to-day basis of the professionals, and that we can reach also the care in a closer way to our population, trying to preserve and respect the cultural differences in our country. That's it. Thank you very much. Thank you, Mr. Antonio Leopoldo, for the important reflections that you brought us. It called for the attention. We called for the attention, and we're very happy in hear your approach about the relation between the attributes of primary attention to health with nutritional care, making a bridge between the policies for basic attention, food and nutrition, and food safety, and reinforcing the importance between transversality between these policies. This focus is also present in the new version of the Matrix of Food and Nutrition, which was launched yesterday, and I remember you all who did not contribute with the Brasilia letter to access the website from E10 and contribute. And also, I invite you to see the launches, the matrix for organization of care, food and nutrition in APS, and the recommendations for in the primary care to health. And now I would like to pass to the comments that we received in the chat. We have some questions for the lecturers. So first of all, for Dr. Salas and Dr. Piccinina Valis from Canada, we have one question. We received the following question. I would like to know if Canada already measured the impact or some dimension of the impact of the 5 A's. Vinicius, can you confirm if it was translated?
Yeah, I could hear the question.
Okay.
Thank you very much. Thank you for that question. Yes, the 5 A's of obesity management, there's been a team at the University of Alberta, and I can send you the link, that has published quite extensively on the implementation of the 5 A's in primary care. And they did a randomized control trial in the city of Edmonton, and where they tested the 5 A's, and it was integrated into the primary care practice in that city. So there are some studies. I will send you the link.
Doutora Salles, você vai projetar o link?
Are you going to write the link where, doctor? Is it in the chat?
Where would you like me to put it, in the chat or in the Q&A chat? There you go. Can you see that link?
No chat.
In the chat, can you see? We're seeing the link. Okay.
Yeah, yeah. So you can see under publications.
Estamos vendo, sim.
Yes, we are watching.
Published papers. There's 19 papers there.
Muito obrigada, doutora Salas.
Thank you very much, Dr. Salas. We have another question for the United Kingdom. And also, I'm going to take the opportunity to do a question for the professionals from Brazil, also for the United Kingdom, which were the main challenges and the main strategies to surpass the biomedical model in the care for people with obesity and other chronic diseases which are not non-transmittable, for Dr. West, please.
Seguida, eu gostaria que...
And then I would like that to be answered also for Fernanda and Patricia after Dr. West's answer. How do you do the planning for the actions with the multi-professional team and UBSs? You have a time to plan? Do you have a time to plan all the activities? Okay, thank you. And now, Dr. West, you can answer your question.
I will try, because we use a variety of methods and a variety of approaches to address the issue of obesity, to address the management, prevention, etc. of diabetes, particularly type 2. And again, it's in context. It's in context. We have a referral system that we apply in the United Kingdom, and we work within a multidisciplinary team. In some, like I say, in some areas, it is a postcode lottery. Dependent on where you live, it will relate to the particular resources you can access. And that may be a factor that will also affect how we approach, the approach that we use. But what we find in primary healthcare in the United Kingdom, the empowerment approach is a very useful tool. Empowerment, in addition to that, behavioral change, not as prolific, but sometimes a plethora, a combination of approaches is what is applied. When you start dealing with policies such as sugar tax policies and other policies to address the issue of obesity, it has an effect. It has an effect, but it's short-lived. You have to get it right at the core of the community that you are working with. You cannot tell my Caribbean parent, for example, to eat less of pasta. They don't eat pasta. They prefer to eat yam and plantain. You need to explain it in terms of choices. Eat what you like, but be aware. And when you get to the core of the culture, and in some cases the race, you get to the core of the issue and you can address it from that point. Sometimes we address issues, and we have learned from experience that when in primary care, we're going into persons' homes, we're going into their space, we're going into where they control. And they will tell us yes, 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 for a limited period until we go through the door, and then they'll revert back to what they were doing anyway. So you have to meet individuals at the culture of where they are. So we use a plethora of approaches in order to answer your question directly. And the other part of the question? Anna? The other part of the question?
No, it's just that, Dr. Rosetta. The other one is for Brazil.
I've got
for
you.
the participants from Brazil.
Thank you.
Thank you
And
very
I'll stop
much.
there. I will stop there. Thank you.
Nós que agradecemos, doutora Rosetta.
We are the ones who thank you, Dr. West. Now, Brazil, you can speak. Now, thank you very much. The issue about planning is very fundamental. I remember that this was very spoke to me very well, in which she suggested that it's understood that it's necessary to have an increase in the planning, it's necessary to have an increase in the meetings, and most of the times, we in the basic healthcare unit and primary attention, we are demanded for the intrinsic care, because people understand that to be working is to be meeting individually.
And there is also, it's necessary to understand these actions that are more generic, that are focused on the prevention. And in terms of these professionals, we managed to get a weekly meeting in the team of the multiple professionals. We have a weekly meeting. And in this meeting, we plan, we assess. Since we are a team that work in 3 basic health clinics, health units, that's the only moment that we can meet and during the week. That's why it's so important for us to tell everyone else what's happening in each of these health units. And another strategy that helps us a lot is the meeting that we hold with every team of the family health program. And every month, the multi-professional unit meets with the family health unit. And so we can start planning, and we say we're thinking about doing this, and then we listen to the team, and then we discuss the cases, we plan activities and other actions as well. That it's really important for us this moment, and to find it's really hard to fight for this space, but I believe that it's worth it. It's going to change a lot, your actions.
À vontade, Patrícia.
Well, can I say? I'm going to talk about my experience, because Curitiba is a very big municipality. We have close to 2 million inhabitants, and my work is exactly planning, differently from other municipalities that are smaller, in which the nutritionist is the one that plans the actions, and he is the one working at the basic healthcare unit. My work is to plan the actions, of course, not in an imposing way, but cooperating with them, with the nutritionists that are at this basic healthcare units, because that is my job. I do this all the time because I'm in management. But I understand that it's not the reality of people who don't, who have a different reality. And the nutritionist is the one planning and working with seeing patients. I just wanted to let this clear. We do have the participation of the nutritionists, and they do have time for planning to carry out these actions that are planned for us in their specific territories, and they have their time with their family healthcare unit.
Perfeito, Patrícia, Fernanda.
Perfect, Patricia. Fernanda, thank you very much for answering our questions. And we're getting close to the end of our broadcast today. We're going to wait for you tomorrow and the third day of the second international seminar. We're going to have more national and international experiences. We're going to have another panel, and see you tomorrow.
Recording stopped.